All right. Take care. May God bless you. And we will meet tomorrow.
Right. So guys, let's start with first topic in autonomic nervous system. So autonomic nervous system, the first topic is urinary incontinence. So if they will ask you what is the best medicine for overflow incontinence, medicines which are best medicine for overflow incontinence, which is also known as atonic bladder. So here the bladder is inactive. So the drug of choice you people are supposed to mark as bithenecol, right? So bithenecol is the best medicine that you can mark over here, right? And bithenecol is cholinergic drug. That is the best answer. The second drug that you can mark over here is neostigmine. So first is bithenecol. The second is neostigmine that you can mark over here. Next is if the patient has urge incontinence, like the opposite of atonic bladder is overactive bladder. So if the patient has overactive bladder, urge incontinence, so here you are supposed to mark drug of choice as beta 3 agonist. So beta 3 agonist is a drug of choice. The medicine name is mirabegron. So mirabegron is a drug of choice for this condition, and almost equally efficient drug is muscarinic 3 blockers. Medicines which are muscarinic 3 blockers, they can be categorized as a second drug of choice or the second group of choice, where we prefer to use the medicine like trospium. So trospium, darifenacin, these are the medicines that we prefer to use under the anticholinergic group of medicines. So although both medicines have almost equal efficiency, but based on the side effect profile, mirabegron is considered as better medicine than the trospium. Now if we talk about stress incontinence, so in stress incontinence, the patient will have the problem of sphincter. So here we have to give a medicine that will cause tightening of sphincter. So which medicines can cause tightening of sphincter? So here the drug of choice is a medicine, we call it duloxetine. So duloxetine is a medicine which is a drug of choice for stress incontinence. This is an antidepressant medicine, belong to a class of SNRI. So these are the three types of incontinence that we have covered in this particular slide. Let's move on to the myasthenia gravis. So the patient of myasthenia gravis can come to you with local muscle weakness. Patient can come to you with generalized muscle weakness, or the patient can come to you with myasthenia crisis, right? So if the patient has come to you with local muscle weakness, if the patient has come to you with local muscle weakness, the medicine that you will mark over here is pyridostigmine. So pyridostigmine is the medicine that is considered as drug of choice. In case pyridostigmine is not given in MCQ, the alternative to pyridostigmine is neostigmine. Alternative to pyridostigmine is neostigmine that you will mark. But whenever we give any of this medicine, we have to give these medicines along with low dose of atropine. So in myasthenia gravis, pyridostigmine, neostigmine, they are always given along with low dose of atropine. Now, after starting this medicine, if the patient disease is not controlled, so the patient muscle weakness is not improved, then the second best option that you can do in this patient is you can add immunosuppressant medicines. You can add immunosuppressant medicines, and among immunosuppressant medicine, you can add the medicines like azathioprine. You can add the medicine like azathioprine. You can add the medicine like mycophenolate and cyclosporine. So these are the three medicines which are preferred in the treatment of myasthenia gravis: azathioprine, mycophenolate, and cyclosporine. But if the patient will have the generalized muscle weakness, so local muscle weakness, most of the time eye muscles are involved. Generalized muscle weakness, we are mainly concerned about the respiratory muscles. We are mainly concerned about the respiratory muscles. So whenever the patient will come to you with generalized muscle weakness, apart from starting the drug therapy, so the same drug therapy you will start. So apart from starting drug therapy, you have to go for thymectomy. You have to go for thymectomy in this patient, and thymectomy can only be done if the patient FEV1. So thymectomy is a procedure that can only be done when the patient FEV1 level is more than 80%. Otherwise, it's not possible to do this thymectomy also. So drug therapy plus thymectomy both are done together in this patient of generalized muscle weakness. Now, after doing this, if the patient disease is not controlled, if the patient disease is not controlled even after doing this procedure, then we have to add immunosuppressant medicines. We have to add immunosuppressant medicines. So immunosuppressant medicines are added in the patient treatment. This is the treatment. Now in patients of myasthenia crisis, guys, In patients of myasthenia crisis, we have to stop pyridostigmine for a time being. So pyridostigmine, which is the overall drug of choice, that need to be stopped. And in patients, we can go for plasmapheresis. So in patients of myasthenia crisis, we can go for plasmapheresis. We can also go for intravenous immunoglobulins. We can also go for intravenous immunoglobulins, and we can also go for IV methyl prednisolone. So IV methyl prednisolone, the short course of steroid, can also be given to the patient. So plasmapheresis, intravenous immunoglobulin, and methyl prednisolone can be given to the patient. This is how we manage a patient of myasthenia gravis, presented to you in 3 different scenarios that we have covered, that how to approach to this patient. Now after this myasthenia gravis, let's talk about some antidotes that can be asked in relation to drugs of autonomic nervous system. So if they ask you the antidotes, if you ask you the antidotes of organophosphate poisoning. So antidote of organophosphate poisoning, guys, you people are supposed to mark atropine. So atropine is a medicine which is an antidote of choice, but along with atropine as a drug of choice, you have to give a medicine that is known as pralidoxime. Right? So atropine is given as a best medicine. Along with that, you have to give pralidoxime as a drug. Now, atropine is a medicine that initially given in a higher dose. So initially we start atropine in a higher dose and we switch to low dose of atropine. We switch to low dose of atropine when we achieve the dryness of secretions. So whenever there is a dryness of secretion or when the chest becomes bilaterally clear. So when the chest is bilaterally clear or there is a dryness of secretion, then we switch to the low dose. So initially we start with the high dose of atropine and we switch to low dose of atropine when there is a dryness of secretion or when the chest is bilaterally clear. And along with atropine, we always give oxime that will help in fast recovery. So the basic purpose of giving oxime is the fast recovery from the poison, that is organophosphate poisoning. Yes, very good. So I can see Dr. Sunny Koshki has given the correct answer. Even the Soturu Goju has given the correct answer. Now, if we talk about atropine and datura poisoning. So atropine poisoning, datura poisoning, belladonna poisoning, same thing. Now, which medicine we can give for this poisoning? So here the answer is physostigmine. So physostigmine is a medicine which is the antidote of choice for atropine poisoning. Now guys, in case of cobra bite, in case of cobra snake bite, the first medicine we have to give is, yes, Dr. HM, you have given the correct answer, it's physostigmine for atropine poisoning. So if we talk about cobra snake bite, the first medicine to be given is anti-snake venom. So anti-snake venom is the first thing to give. Now after anti-snake venom, we will give atropine to the patient, and immediately after atropine, we will give neostigmine to the patient. Right? So we give anti-snake venom, then we give atropine. After that, we will give neostigmine to this patient. This is how we approach to a patient of cobra snake bite. Right? This is the sequence of the drugs that we will give. Now, in patients of scorpion bite or hypertension crisis, scorpion bite causing the hypertension crisis, we have to give antivenom first. We have to give antivenom first. Now, even after giving antivenom, if the BP is still high. So, after giving antivenom, if the patient BP is still high, then we have to give the prazosin as a antihypertensive drug. So, prazosin can be given as an antihypertensive drug. So if the patient BP is still high after giving the antivenom, we have to give prazosin to this patient. Now for the theophylline toxicity, the patient can have the arrhythmias, and because the patient will have the arrhythmias, esmolol is the antidote of choice, or beta blockers we can say are the antidote of choice. And in treatment of beta blocker toxicity, what is the name of the antidote, guys? So I have written with a white color that you cannot see. Anyone can answer. What is the antidote of beta blocker toxicity? Yes, Dr. HM has given the correct answer. So glucagon is a medicine. Dr. ZM, Dr. Anjali Prasad, all of you have given the correct answer. Glucagon is a medicine that is an antidote of choice for beta blocker toxicity. Now let's talk about Alzheimer's disease. Now in patients of Alzheimer's disease, patient can have the main symptom as dementia. So patient will come to you with dementia. So which medicines are memory enhancing drugs? So medicines which are memory enhancing drugs. So medicines which are given for symptomatic relief. So symptomatic relief means these medicines can improve the patient memory. So here we have the drug of choice. Here we have the drug of choice, donepezil. So donepezil is overall the drug of choice for Alzheimer's disease. This is the most efficient drug which is preferably given by oral route. This is preferably given by oral route. But recently in America, this medicine has got approval from the treat in the form of skin patch also. So donepezil given by oral route, but can be given in the form of skin patch also, right? So donepezil dose modification not required, right? So no dose modification required. So no dose modification required in patients of CKD and CLD. This is a wonderful medicine that is donepezil. Now guys, we have a drug that is rivastigmine. Rivastigmine is a medicine which is more famous in the form of skin patch, right? This is more famous in the form of skin patch. So usually what we do when the patient is not able to tolerate, when the patient is not able to tolerate the donepezil because of a side effect that is diarrhea. So donepezil side effect is diarrhea. So the patient is not able to tolerate this donepezil diarrhea. We shift the patient to rivastigmine skin patch. Now, guys, when we start donepezil in this patient for the symptomatic relief, if the patient is not getting the relief, right? So, if the patient symptoms are not getting relief, patient is not finding the relief, we usually give treatment for 6 months. We give donepezil treatment for 6 months. Then we will add the disease modifying drugs. So, after starting this symptomatic relief medicines, after 6 months of treatment, we will add the disease modifying drugs. So we have a disease modifying drug which is a NMD receptor blocker. So I can see Dr. Nobita has given the correct answer. It's memantine. So after this donepezil, we can add in the patient treatment memantine. We have a new medicine which is beta amyloid protein inhibitor. So beta amyloid protein inhibitor, drug name is aducanumab. So aducanumab is a medicine that can be added in the patient treatment. So aducanumab can be added in the patient treatment in case donepezil is not able to control the symptoms. Now we can also add some antioxidant medicines like we can add carnitine. We can add coenzyme Q. So coenzyme Q, vitamin E, carnitine, these medicines can be added in the patient treatment as an antioxidant drugs. Now we have some ACLS algorithms. We call them advanced cardiac life support algorithms, right? So advanced cardiac life support algorithms, ACLS algorithm. So in this algorithm, guys, for the treatment of bradycardia, drug of choice given as atropine. So atropine is given as a drug of choice, and the starting dose of atropine for the bradycardia is 1 milligram. Starting dose of atropine for bradycardia is 1 milligram, but the maximum dose of atropine that we can give to the patient is 3 milligram. Maximum dose we can give 3 milligram. Starting dose is 1 milligram, but even after giving 3 milligram, patient bradycardia is not controlled. So if the patient bradycardia is not controlled even after giving the 3 milligram, we can add the medicines like adrenaline or the dopamine. So adrenaline and dopamine are two more medicines that we can use for the treatment of bradycardia. So these medicines can be added in the patient treatment. Whenever the patient will come to you with cardiac arrest, so cardiac arrest presentation can be non-shockable rhythm, can be shockable rhythm. So non-shockable rhythms are asystole and the pulseless electrical activity. So for non-shockable rhythm, after doing CPR 2 times, we will give the medicine like adrenaline. So adrenaline is a medicine that is given in a dose 1 milligram. Adrenaline is a medicine that is given in a dose of 1 milligram, and the concentration of drug is 1 is to 10,000 that we can give by IV route or by the intraosseous route. Now, whenever we have to give the medicine by intraosseous route, we can use the bone tibia. So tibia is a bone where we mostly use this intraosseous route to give the adrenaline in cardiac arrest, right? And if the question is asked to you, how much volume of the drug that you will inject is equal to 10 ml. So 10 ml is the volume of the drug that you will inject in the patient treatment. Right, guys? So adrenaline is the drug of choice for cardiac arrest, where the patient is presented to you with asystole and pulseless electrical activity. Now, when the patient has come to you with shockable rhythm means ventricle fibrillation and pulseless ventricular tachycardia, right? Patient has come to you with ventricle fibrillation and pulseless ventricular tachycardia. So here we will give the shock first, followed by the CPR. We give the shock first, then the CPR. This is done 2 times. So shock followed by CPR. This is done 2 times. Now after that, we will give the same adrenaline like it is mentioned over here. So I will give adrenaline, but if there is a recurrence of this arrhythmia again and again, even after giving adrenaline to this patient, as well as the shock is given to the patient, then we can switch to the medicines like amiodarone. So amiodarone is a medicine that is given to a patient. First dose 300 milligram, second dose 150 milligram given to this patient. In case amiodarone is not given in MCQ, you can switch to lidocaine The first dose 100 milligram approximately, second dose 50 milligram approximately. Very good. So I can see most of you are able to answer correctly all these things. Now let's move on to the third thing, that is tachycardia. So whenever the patient will have the tachycardia, we call it paroxysmal supraventricular tachycardia. So here the adenosine is drug of choice. So adenosine is a medicine which is a drug of choice. The first dose of medicine is 6 milligram. Second dose of medicine is 12 milligram. This is given in the form of IV bolus. This is given in the form of IV bolus, which is followed by the saline push. So this is given in the form of IV bolus followed by the saline push. So this adenosine is given for the treatment of PSPT in this patient, right? So this is all about the ACLS algorithm. After this is ACLS algorithm, we can discuss some medical emergencies. So if we talk about medical emergencies, the first is cardiogenic shock. So as per the definition of cardiogenic shock, if we do the echocardiography, whenever the ejection fraction comes out to be less than 35 to 40%, this is known as cardiogenic shock. Now, when the cardiogenic shock is associated with oliguria, when the cardiogenic shock is associated with oliguria, drug of choice you will mark as dopamine. So dopamine infusion is a drug of choice in a dose 2 to 10 microgram per kg per minute. So this is the dose of the dopamine that you will mark as a drug of choice. Now, in patients of cardiogenic shock with low blood pressure, so low blood pressure means the systolic blood pressure is less than 80 to 90. Systolic blood pressure I am talking about. So here you will mark noradrenaline as a best medicine, as a best inotropic drug. But if the patient BP is maintained, patient BP is more than 80 by 90. So here you will mark dobutamine as a drug of choice. So here you will mark dobutamine as a drug of choice. So dobutamine is a drug which is a pure beta 1 agonist. So this can be marked as a drug of choice, right? Now, in patients of septic shock, in patients of neurogenic shock, hypovolemic shock, and hypotensive shock, any of the clinical scenario given to you, you will mark drug of choice as noradrenaline. And in case noradrenaline is not given in MCQ, you will mark dopamine. You will mark dopamine as a drug of choice. Now, dopamine dosage is more than 10 microgram per kg per minute. So here the schedule of the dopamine is more than 10 microgram per kg per minute that you will mark as a best medicine. Now for the treatment of anaphylactic shock. For the treatment of anaphylactic shock, drug of choice is adrenaline. Now the dose in the adult patient. In adult patient, the dose of the medicine is 0.5 milligram. So medicine dose is 0.5 milligram. Concentration that we use is 1 is to 1000. So 1 is to 1000 is the concentration that we use. The route of administration is intramuscular route. So intramuscular route 1 is to 1000 and 0.5 milligram is the dose. And if they will ask you how much volume you have to inject, the volume is 0.5 ml. The volume is 0.5 ml. So this is the route, we call it intramuscular route. But if we want to give medicine by IV route, if we want to give medicine by IV route, the dose of the medicine is zero point 0.1 milligram. Right? So the dose of the medicine is very low, that is 0.1 milligram. The concentration is 1 is to 10,000. Concentration is 1 is to 10,000 and the volume that we have to inject is total 1 ml. So volume is 1 ml. So this is the preferred one. The intramuscular route is preferred one. The IV route is the second choice that we can give. Right. Okay. So Dr. Amit, I will go a bit slow, but I have to finish all the syllabus. So I'll try to go a bit slow. Okay. Okay, so guys, like Dr. Kaushiki has already mentioned, whenever we have to give the intramuscular injection of adrenaline, whenever we have to give intramuscular injection of adrenaline, right? So which muscle we will use? So answer is thigh muscles. So lateral part of thigh. So lateral part of thigh that we will use the vastus lateralis. So the muscle name is vastus lateralis. So this muscle we will use for the injection of adrenaline for the treatment of anaphylactic shock. Now, whenever patient will come to you with heart block, so here you will mark the drug of choice as atropine. So atropine is a drug of choice for the treatment of heart block. So these are the medical emergencies that we people have covered. Right? So medical emergencies we people have covered. Now after the medical emergencies, let's talk about the hypertension. What is the treatment of hypertension? So guys, whenever patient comes to us with acute hypertension, so whenever the patient will have the acute fall in blood pressure, drug of choice you will mark as noradrenaline. So for the treatment of hypertension, the medicines that we use are known as vasopressors. Medicines are known as vasopressors, right? So noradrenaline is a drug of choice for acute hypertension. But for chronic or the orthostatic hypotension, first of all, we will go for the conservative management. First of all, we will go for the conservative management. If conservative management is not able to control, if conservative management is not able to control, you will mark medicine that is fludrocortisone. So fludrocortisone you will mark as a drug of choice. So fludrocortisone tablets you will mark as a drug of choice. But even after giving fludrocortisone as a drug of choice, the BP is not controlled. So even after giving fludrocortisone, patient BP is not controlled. Then we will give the medicines which are alpha 1 receptor agonist. Medicines which are alpha 1 receptor agonist. So we have the medicines like midodrine. We can give midodrine. We can give the medicine like droxidopa. So midodrine and droxidopa are the medicines. Midodrine, droxidopa are the medicines that we can add in the patient treatment. Now, when the patient will have hypotension that is associated with spinal anesthesia, right? So when the patient will have hypotension associated with spinal anesthesia, here there are two possibilities. The first possibility is hypotension that is seen after spinal anesthesia associated with normal heart rate or maybe associated with tachycardia, first possibility. The second possibility, hypotension associated with bradycardia. So when the patient is having the hypotension associated with normal heart rate or tachycardia, here you will mark phenylephrine. So phenylephrine is a medicine which is a vasopressor of choice. So this will act on alpha 1 receptor. So this is a vasopressor of choice for hypotension associated with spinal anesthesia with normal heart rate or increase heart rate. But if the patient will have the hypotension associated with bradycardia, here you will mark ephedrine. Here you will mark ephedrine as a vasopressor of choice. So ephedrine can be marked as a vasopressor of choice in patients who have hypotension associated with bradycardia, right? So this is the management of hypotension that we people have covered in this slide, right? So we have covered this management in this slide. Now come to the medicines that are given for the treatment of bronchial asthma. Now if we talk about medicines which are given for bronchial asthma, we have the medicines which we call them controllers. So medicines which are controllers, basically we have two types of medicines which we give for bronchial asthma. One is known as controllers, second is known as relievers. So one is known as controllers, second is known as relievers. Basically relievers are also known as bronchodilators. Relievers are also known as bronchodilators. So we have the controllers, we have the relievers. Now, if we talk about the controllers, controllers are the drugs which are the anti-inflammatory medicines. These are the drugs which are anti-inflammatory drugs. So here the overall drug of choice for maintenance treatment of bronchial asthma is inhalational corticosteroids. So inhalational corticosteroids like the medicines we have budesonide and fluticasone. So budesonide, fluticasone are the medicines that are very commonly used as a maintenance treatment of bronchial asthma. Now, the most common side effect of inhalational corticosteroid is oral candidiasis. So the most common side effect is oral candidiasis, oral thrush. So whenever we take steroids by inhalational route, most common side effect is oral candidiasis, oral thrush. Now, whenever this oral thrush or oral candidiasis has occurred, how we can prevent, like this is a very common side effect, so we need to prevent the side effect. So we can prevent the side effect by advising the patient to go for mouth rinsing. So by advising the patient to go for mouth rinsing, as well as by using a device, we call it spacer. So we can tell the patient to use spacer or can go for mouth rinsing after intake of drug. This is how we can prevent this oral candidiasis. Now if the question is asked to you how we treat this side effect as oral candidiasis, then you will say initially you will start the local antifungal drug. So first of all, you will give the local antifungal drug. So first of all, you will give the local antifungal medicines. So which local antifungal drugs you will give? So answer is clotrimazole. So the medicine name is clotrimazole. So clotrimazole is the local antifungal that you can give. The second you can give is nystatin. So clotrimazole and nystatin are the two local antifungal drugs that you can give to the patient. But after giving this local antifungal, if the patient disease is not controlled, you have to give the systemic antifungal drug. You have to give the systemic antifungal drugs. And what is the drug of choice, guys? So the drug of choice, there is a systemic antifungal drug, which is overall the drug of choice for oral candidiasis. So here the drug name is fluconazole. So fluconazole is a medicine which is overall a drug of choice for this oral candidiasis, which is treated by systemic antifungal drug. Now, apart from that, we have the medicines which are given for bronchial asthma, like we have the drugs which are leukotriene synthesis inhibitors. So, which medicine is leukotriene synthesis inhibitor? We have a drug Xyluton. Xyluton is a medicine which is leukotriene synthesis inhibitor. This medicine is inhibitor of lipoxygenase enzyme. So, by inhibiting lipoxygenase enzyme, this medicine can stop the leukotriene synthesis. The medicines which are leukotriene release inhibitors, we call them mast cell stabilizers. So mast cell stabilizers are the drugs which are leukotriene release inhibitors. All medicines are having the word chrome in their name. All medicines are having the word chrome in their name. These are the mast cell stabilizers. Now the medicines which are leukotriene receptor inhibitors. Medicines which are leukotriene receptor inhibitor. Example is montelukast. So montelukast is a medicine which is leukotriene receptor inhibitor. Now this medicine is given by oral route, and this medicine will not produce any significant side effect. So this medicine has no significant side effect. So it is quite safe to use in children. So this medicine is quite safe to use in children because this medicine has no significant side effect. The drug name is montelukast. So montelukast is the drug which is leukotriene receptor inhibitor given by oral route, no significant side effects, safe to use in children. These are the medicines which are the leukotriene modifying drugs. Now we have a drug which is IgE inhibitor, but the name of the medicine I have forgotten. So you people have to help me out in this. Which drug is IgE inhibitor? So name of the drug I have forgotten. Please tell me which drug is IgE inhibitor. Anyone can answer this question? I know most of you are able to answer this question. Okay. Yes, so Dr. ZM. Dr. ZM has given the correct answer. Yes, Dr. Nakshatra, Samina, Mamba, Anjali, all of you have given the correct answer. So we have a drug, omalizumab. So we have a medicine that is omalizumab. So omalizumab given by subcutaneous route. Omalizumab given by subcutaneous route, and one of the important side effect of this medicine is hypersensitivity reaction. So although it's IgE inhibitor, but one of the important side effect is hypersensitivity reaction given by subcutaneous route to a patient. Now this medicine, apart from this bronchial asthma, it is also given for the treatment of urticaria. This medicine is also given for the treatment of urticaria. Drug name is omalizumab. So these are the medicines which are known as controllers, or we call them anti-inflammatory drugs given for bronchial asthma. Then we have the second class of medicines, we call them relievers. We have a second class of drugs, we call them relievers. Basically, these medicines are bronchodilators. So these medicines are bronchodilators. So we have the drugs like beta 2 agonist. Medicines are like beta 2 agonist. So beta 2 agonist medicines are SABA and LABA. Short acting and long acting beta 2 agonist. So here the classical example of short acting medicine is salbutamol. Now salbutamol is a medicine when given to a patient. This medicine can lead to 6 important side effects that we can remember with the mnemonic 3T and 3H. So salbutamol is a beta 2 agonist that can lead to 6 important side effects. We can remember with the mnemonic that is 3T and 3H. So whenever we give this medicine, the most common side effect of this medicine is tremors. Most common side effect is tremors. The second most common side effect is tachycardia. And when we give this medicine for a longer time, this medicine is associated with the problem of tolerance. We also call it tachyphylaxis, right? So medicine can cause tremors, tachycardia, tolerance, which is very fast to develop. We call it tachyphylaxis. Now here we have the H also. Now H stands for hyperglycemia. So salbutamol therapy later on will cause hyperglycemia. This can also cause hypotension. This can rarely associated with hypotension and can result in hypokalemia. So can cause hypokalemia, hypotension, hyperglycemia. These are the 6 important side effects caused by this medicine, that is salbutamol. Now we have a drug which is long-acting beta-2 agonist. So long-acting beta-2 agonist that is given for bronchial asthma. One of the example is formoterol. Now formoterol is a long-acting medicine also having the fast onset of action. And because of this fast onset of action, this is the most preferred drug. This is the most preferred bronchodilator for acute bronchial asthma. This is the most preferred bronchodilator for acute bronchial asthma. But whenever we use this medicine for acute bronchial asthma, this medicine is given along with inhalational corticosteroids. This medicine is given along with inhalation corticosteroid. Drug name is Formoterol. Started with F. Medicine has fast onset of action. So we have covered the first group of bronchodilator. Medicines are SABA and LABA. Now we have a second group of medicines which are muscarinic blocker. Now the drugs which are muscarinic blockers, they are the anticholinergic drugs. These medicines are the anticholinergic medicines. So the medicines are short-acting and the long-acting muscarinic antagonist. Medicines are short-acting and long-acting muscarinic antagonist. So the medicine which is short-acting muscarinic antagonist, drug name is ipratropium. So ipratropium is a drug which is a non-selective drug in its action. So this medicine has non-selective action in the body. So apart from blocking M3 receptor, this medicine can also block M2 and M1 receptor. So this medicine can block M2 and M1 receptor also. As a result of that, guys, this medicine can cause dry mouth as a side effect. This medicine can also result in tachycardia as a side effect. So medicine can cause dry mouth and tachycardia as a side effect because the drug has non-selective action in the body. So medicine has non-selective action in the body. Now the medicine which is long-acting muscarinic antagonist, drug name is tiotropium. Now tiotropium is quite selective medicine. So this medicine is quite selective in its action. So this medicine mainly blocker of M3 receptor with very less action, on muscarinic 1 receptor. And tiotropium is overall considered as maintenance treatment of choice for COPD. This is a drug of choice for maintenance treatment of COPD, but it can also be given for bronchial asthma. It can also be given for bronchial asthma. Now we have a medicine that is theophylline. Now theophylline is a drug that is derived from the component that is T. So this medicine is derived from the component T, where the T stands for theophylline. So we have covered during our lecture also. T stands for theophylline. Here the E stands for enzyme inhibitor. So this medicine is a phosphodiesterase enzyme inhibitor. This is a phosphodiesterase enzyme inhibitor. Plus this medicine is also having the letter A. So here the A stands for, it is a adenosine A1 receptor inhibitor. So theophylline is a medicine. This medicine is derived from the T, right? So here the T stands for theophylline, E stands for enzyme inhibitor, A stands for adenosine A1 receptor blocker. It is used as a bronchodilator. Now, when this medicine is given as a drug, now by blocking the phosphodiesterase enzyme, this medicine can increase the level of cyclic AMP in the body. By inhibiting the phosphodiesterase enzyme, this can increase the level of cyclic AMP in the body, can lead to four important side effects, which we can remember with a salbutamol, that is 2T and 2H. So just like salbutamol, we can remember this medicine can also cause tremors, tachycardia. This medicine can cause tremors, tachycardia. This medicine can also cause hyperglycemia, hypotension. So four side effects caused by this medicine, like salbutamol. So this medicine can cause tremors, tachycardia, hyperglycemia, hypotension. Now this medicine is also adenosine A1 receptor blocker. So by blocking adenosine A1 receptor, this medicine can cause CNS center stimulation. Medicine can stimulate the central nervous system, can result in insomnia, can result in seizures as a side effect, can result in tachypnea by stimulating the respiratory center, and can cause tachycardia by stimulating the vasomotor center. So by stimulating vasomotor center, tachycardia, tachypnea, insomnia, seizures, all the side effects can occur. Plus by blocking this receptor, the medicine can result in diuresis. So just like tea and coffee, this medicine can result in diuresis as a side effect. So like tea and coffee, this medicine can cause diuresis as a side effect. Plus the medicine most common side effect is nausea, vomiting. That is also due to this adenosine A1 receptor, right? So nausea, vomiting is the most common side effect, that is also due to the blocking of adenosine A1 receptor. Yes, Dr. Samina, tachycardia can be caused by both pathways, right? So tachycardia is a side effect that is by both the mechanism. Now, this theophylline has three problems in pharmacokinetics. There are three problems in pharmacokinetics of this theophylline. So, what are the three problems that occur with theophylline in its pharmacokinetics? The first problem with theophylline is a drug which has the narrow therapeutic index. The first problem is the medicine has narrow therapeutic index. The second problem is this medicine follows zero order kinetics. because of the liver enzyme. We call it CYP1A1 and 1A2, right? So it's a narrow therapeutic index medicine, and medicine has zero order kinetics. Plus, the third problem is the medicine has lot of drug interaction. Medicine is associated with lot of drug interaction. So this medicine can interact with liver enzyme inducers as well as inhibitors. This medicine can interact with liver enzyme inducers as well as inhibitor. So this is very, very common and very, very important for the exam. Guys, theophylline is a drug which is very, very, very important for your uh, this NEET PG exam, because every alternate year they ask this question on theophylline. It's a very important drug, guys. So please remember the medicines which are liver enzyme inducers and the medicines which are liver enzyme inhibitor. The names of the medicines are very important for the exam to find out all the important drug interactions. Right? One more bronchodilator, magnesium sulfate. This is just for the sake of the name I have covered. Guys, please remember, whenever the patient will have the status asthmaticus, whenever the patient suffer from status asthmaticus, whenever patients suffer from status asthmaticus, which is also known as acute severe bronchial asthma. So whenever patients suffer from status asthmaticus, which is acute severe bronchial asthma, we can use almost all bronchodilators. So all bronchodilators are useful in severe bronchial asthma. Particularly, we use the fast-acting bronchodilator. So fast onset bronchodilators are useful. So all bronchodilators are given for status asthmaticus, which is acute severe bronchial asthma. Plus, we can also use steroids. So steroids can be given by IV route, can be given by oral route during the acute severe bronchial asthma. So if the question is asked to you, which medicines are given for status asthmaticus, you will mark like this way. For the treatment of status asthmaticus, we can use salbutamol, we can use ipratropium because these two are short acting and the fast acting. We can also use theophylline, aminophylline. We can also use magnesium sulfate. Plus, we can use steroids. The special mention about the montelukast. Please remember, montelukast is a drug which is not useful. Montelukast is a medicine which is not useful for bronchial asthma because of the slow onset. So in acute bronchial asthma, I'm not making an error over here. So montelukast is not given for status asthmaticus. It has a slow onset of action. It is not used. Now this is a stepwise treatment of bronchial asthma. So this will be covered in your medicine class also. Nothing to teach here. Just remember the steps by which we can treat the bronchial asthma. So whenever the disease will worsen, we will move from step 1 to step 5 or maybe the step 6 also sometimes. But when the condition will improve, when the patient bronchial asthma will improve, we also go step down. Right? Okay, now in treatment of COPD, guys, we have limited options. So we have covered already long-acting muscarinic antagonist. Long-acting muscarinic antagonist, tiotropium is a drug of choice. If the disease is not controlled, we can add. The medicines like LABA and VLABA. So in the treatment of COPD, first is tiotropium. If the disease is not controlled, we can add long-acting or the very long-acting beta-2 agonist. Medicines are like olodaterol, indacaterol, and vilanterol. Right? So Dr. HM, aspirin-induced bronchial asthma. Try to understand. In aspirin-induced bronchial asthma, we can give montelukast. The disease is known as aspirin-exacerbated respiratory disease. So the disease is known as aspirin-exacerbated respiratory disease, where the drug of choice is montelukast. So drug of choice is montelukast to maintain this patient, right? So this is not a very severe asthma. So montelukast can be given for the treatment, but not the acute attack patient will ever get, right? So aspirin-exacerbated respiratory disease, we can use montelukast. Now we have the next condition, that is benign prostate hyperplasia. Now in treatment of benign prostate hyperplasia, we have the three types of medicines that we can use. Medicines that can be used for dynamic component. Medicines which can improve the dynamic component of the patient. So dynamic component means the medicines which will improve urination. Medicines that can improve urination in the patient. So in patients of BPH, medicines are given to improve urination. That is also known as dynamic component. So here the drug of choice you will mark as tamsulosin. So Dr. Monkey is answering all questions correct. So Monkey has given the correct answer, tamsulosin. So tamsulosin is a medicine which is a drug of choice. It is a selective alpha 1A receptor blocker, and this medicine will give you the fastest relief. This medicine will give fastest relief within 15 days. So within 15 days of therapy, patient can have the relief and the medicine can be continued for lifetime. Medicine can be continued rest of the life, but medicine need to be given minimum for 15 days, but provide the fastest symptomatic relief. Now, whenever this medicine is given, the important side effect of this medicine you can remember with the mnemonic fire. So medicine side effect we can remember with the mnemonic FIRE, where the FI stands for floppy iris syndrome. So this medicine can cause floppy iris syndrome, and the medicine can also result in retrograde ejaculation. So floppy iris syndrome, retrograde ejaculation, important side effect of this drug, that is tamsulosin. Now guys, apart from tamsulosin, we can also use the medicine like elfuzocin, sustained release tablets, right? So alfuzosin sustained release tablet we can use. We can also use the medicine like doxazocin and terazosin. So doxazocin, terazosin are two long-acting medicines. These are the two long-acting medicines. They can also be given for the treatment of this condition. But these three medicines, when we use, there is a risk of hypotension. So risk of orthostatic hypotension is very high. So risk of orthostatic hypotension is very high. That's why tamsulosin is overall the best medicine. So if you ask me which medicines are best medicine, so this is the group of medicines which are alpha blockers. They are the best medicines to improve the urination. Now, second is the static component. Medicines which are given for the static component. So static component means we have to reduce the size of the prostate. We have to reduce the size of the prostate. Now, to reduce the size of the prostate, the drug of choice is 5-alpha reductase inhibitors. So, guys, in case you have started tamsulosin and the patient's symptoms are not controlled. So, after starting tamsulosin, patient symptoms are not controlled after 15 days, after 21 days, or after 1.5 months of therapy, then we can add 5-alpha reductase inhibitor. So we can add the medicines which are 5-alpha reductase inhibitor. Now these medicines minimum given for 6 months. So medicines need to be given minimum for 6 months. Now these medicines names are like finasteride and dutasteride. So finasteride, dutasteride are the two medicines which belong to this class. Now these medicines, the important side effect is they can reduce the level of prostate specific antigen. They can reduce the level of prostate specific antigen, and in this way the physician can miss the diagnosis of cancer. Physician can miss the diagnosis of prostate cancer because they reduce the prostate specific antigen. Now the third is the patient will also have the associated symptoms. Patient can also have the associated symptoms like the urgency or the lower urinary tract symptoms. So for this we can give the previously discussed medicines like mirabegron. So mirabegron can be given. Sorry, please make a correction. We can use the medicines like M3 blocker, like we have discussed previously, trospium. So trospium can be given and beta 3 agonist mirabegron can be given. Now in this patient, guys, we can also give one more medicine, that is phosphodiesterase 5 inhibitor. So phosphodiesterase 5 inhibitor, this will help in proper urination. This will help in proper maintenance of the patient's stream so that the urine will not get spilled on the patient clothes. Sildenafil can be given. So phosphodiesterase 5 inhibitors can be given to this patient. Right. So this is all about BPH. Now, after this BPH, we can discuss the pheochromocytoma. Now, guys, for the pheochromocytoma, please remember, whenever we have to make the diagnosis, first of all, we will go for the urine VMA level. We go for the urine VMA level. After that, we confirm the diagnosis by the MRI scan. But there was a history when we used to give some drugs to make the diagnosis. So the drugs that were used in past are phentolamine. So phentolamine and clonidine were the two medicines. Phentolamine and clonidine were the two medicines. These medicines were given in history to make the diagnosis. Uh, Dr. Happy, I will share this PDF with you after the class. Like whatever you want, I'll share with you. I've already shared the blank PDF. After the class, I'll share the filled PDF. I don't have any problem because this class is for you. All this content is for you. मुझे तो already आता है. I already know this content, so this is no use of me. This class and everything is for you. Anything which is beneficial of your for you, I'll share it with you. No problem. So you can listen it. In case you can note down, it's very good because you people know this point. Like if you make your own notes, that's always be beneficial instead of reading someone else's notes. Okay, yes. So after making the diagnosis, guys, the best treatment for pheochromocytoma is surgery. So best treatment for pheochromocytoma is surgery. So preoperatively, Preoperatively, whenever we have to take the patient for surgery, we have to reduce the patient blood pressure. We have to reduce the patient blood pressure preoperatively. So which drug is drug of choice to reduce the blood pressure? Answer is phenoxybenzamine. So phenoxybenzamine is a non-selective alpha 1 and alpha 2 blocker. It's a non-selective alpha 1. Okay, so I'll go a bit slow. I will use phenoxybenzamine alpha 1 and alpha 2 combined blocker, right? So it's a combined alpha 1 and alpha 2 blocker. Drug name is phenoxybenzamine. Now this is a irreversible blocker. This medicine is an irreversible blocker of alpha receptor. This is the medicine which is an okay, Dr. Siddharth, you want to look at me? Okay, I'll give you time. You can look at me now. No problem at all. So what we are discussing, guys, we are discussing pheochromocytoma. There we have discussed that treatment of choice is surgery. So there was a time when we used to give drugs to make the diagnosis. So sometimes they ask the old MCQ, right? So we used to give medicines to make a diagnosis in history, that is phentolamine and clonidine. But nowadays we go for urine VMA level and the MRI scan. Now, once the diagnosis is confirmed, preoperatively, preoperatively we have to control the patient blood pressure. So I will give okay, good. Now you are pampering me, eh? Lab cholecystectomy, lab chole. So phenoxybenzamine is an irreversible alpha 1 and alpha 2 blocker. This is the medicine which is a long acting drug. This is a long acting drug because it is an irreversible blocker. So this is a drug of choice. In case the BP is not controlled, in case the BP is not controlled by phenoxybenzamine, then we can add the second medicine, that is me-tyrosine. So me-tyrosine is a medicine that we can add in the patient treatment. So we can add me-tyrosine as a second best medicine to control. So me-tyrosine is a drug which is a tyrosine hydroxylase enzyme inhibitor. This is a tyrosine hydroxylase enzyme inhibitor. So this medicine we can add in the patient treatment. So this medicine we can add in the patient treatment. Now tyrosine hydroxylase is a rate limiting enzyme in synthesis of noradrenaline and the adrenaline. So this is a rate limiting enzyme in synthesis of adrenaline and non-adrenaline. So when we add me-tyrosine, now the synthesis of adrenaline and the non-adrenaline will go down. So this is how we control the BP, right? Now after this hypertension, guys, along with the hypertension, we also have to control the patient heart rate. Now to control the patient heart rate, we can use the beta blockers. We can use the beta blockers, but we always prefer to use generation 2 and 3 beta blocker. We always prefer to use generation 2 and 3 beta blockers. Generation 1 beta blockers are contraindicated because generation 1 medicines can cause vasoconstriction. So generation 1 medicines can cause vasoconstriction as a side effect. So generation 1 medicines are contraindicated. Generation 2 and 3 medicines are used to control the heart rate. This is how we prepare the patient for surgery. We control the patient BP. We also control the patient heart rate. Now, next is intraoperative hypertension crisis. Next is intraoperative hypertension crisis. Jyoti Sharma, metirapon is a drug for Cushing's disease. That is different from metyrosine. Metirapon is different, that is given for Cushing's disease. Here we are talking about pheochromocytoma. We are talking about the problem of adrenal medulla. When I talk about problem of adrenal cortex, then the metirapon will come. Now for the when you take the patient for surgery, patient can have intraoperative hypertension crisis. Now for intraoperative hypertension crisis, drug of choice is sodium nitroprusside. So sodium nitroprusside is a drug of choice for intraoperative hypertension crisis. But one of the important side effect of sodium nitroprusside is cyanide toxicity. So one of the important side effect of this medicine is cyanide toxicity, sodium nitroprusside, which can reduce the SpO2 level during the surgery. So cyanide toxicity caused by nitroprusside can reduce the level of oxygen during the surgery. So here we have to give the antidote. Here we have to give the antidote. So what is the name of the antidote for the cyanide toxicity? So the antidote of choice is hydroxycobalamin. So hydroxycobalamin, which is the inactive form of vitamin B12. It's an inactive form of vitamin B12. So this can be given as an antidote of choice for cyanide toxicity caused by sodium nitroprusside. This is for the intraoperative crisis. Now, in case sodium nitroprusside is not given in MCQ, they will ask you what is a second drug of choice for intraoperative crisis in pheochromocytoma. You will mark phentolamine. You will mark phentolamine as a second drug of choice, right? Now, phentolamine is also a non-selective alpha 1 and alpha 2 blocker. Phentolamine is also non-selective alpha 1 and alpha 2 blocker, but this is a reversible blocker. If you compare this medicine with phenoxybenzamine, phenoxybenzamine is irreversible blocker. This is a reversible blocker. So this medicine has the short action in the body in comparison to phenoxybenzamine. This is a second drug of choice for intraoperative hypertension crisis that patient can suffer from during the pheochromocytoma surgery. So this is how we manage a patient of pheochromocytoma. Now guys, one thing like in case phenoxybenzamine is not given here for the hypertension, the second drug that I can use is prazosin. This is a high level question in case they will not give you phenoxybenzamine just to trap you. So prazosin also has some role, like alternative of phenoxybenzamine is prazosin. You will not add prazosin as a second drug because both phenoxybenzamine and prazosin are alpha blocker. So phenoxybenzamine is first, but the second, like the alternative of phenoxybenzamine, in case it is not available, so prazosin can be given. But the second drug of choice is always metyrosine. So this is the one that you will add in the patient treatment. Now, after this pheochromocytoma, guys, we have the topic anti-glaucoma drugs. So, if we talk about this topic, anti-glaucoma drugs, so medicines which are given for glaucoma, there are two types of medicines. Treatment of glaucoma, two types of medicines. Number one, medicines which can increase aqueous humor drainage, or the medicines which can reduce aqueous humor synthesis. Medicines which can increase aqueous humor drainage, or the medicine that can reduce aqueous humor synthesis. Now let's talk about the medicines which can increase aqueous humor drainage. Now there are two types of drainage, trabecular drainage and uveoscleral drainage. So the medicine that can increase trabecular drainage, drug name is pilocarpine. So the medicine name is pilocarpine, and pilocarpine is a medicine that starts with the word PI. This is the eye drop. This starts with the word PI. So PI means this medicine can make the pupil pinpoint. So this will make your pupil pinpoint pilocarpine and open the angle in which the drainage of aqueous humor will take place. This will open up the angle in which the drainage of aqueous humor will take place. So pilocarpine is the one that will make the pupil pinpoint, and this will start the aqueous humor drainage. Trabecular drainage will increase. The drug name is pilocarpine. Now this is the medicine which is the first line drug. This is the first line drug that is given for the treatment of acute angle closure glaucoma. This is the first line medicine that is given for the treatment of angle closure glaucoma. First line drug that is given for acute angle closure glaucoma, and when given to a patient, this medicine can lead to four important side effects which we can remember with the mnemonic 4 P's. So pilocarpine starts with P, can cause P, that is pinpoint pupil, and can cause four side effects that start with P. For example, this medicine can make the pupil pinpoint, so our vision of the patient remain deteriorated. Number two, this medicine can cause punctum blockage. Second side effect of the medicine is punctum blockage. Third side effect of the medicine is peripheral retinal detachment, and the medicine is pain in eyes. So Dr. Kaushiki, you remember everything. I'm so happy to see that you remember this mnemonic, right? So this will cause pinpoint pupil, punctum blockage, peripheral retinal detachment, and pain in the eyes. The drug name is pilocarpine, that is given as a drug which will increase the trabecular drainage. Now, the second medicine that can increase the trabecular drainage, drug name is netarsudil. So the second medicine which can increase the trabecular drainage, medicine name is netarsudil. So netarsudil is a medicine that will increase the trabecular drainage, and this medicine acts by inhibiting the Rho kinase enzyme. So this medicine can increase the trabecular drainage by inhibiting the Rho kinase enzyme. So this is the one that can increase the trabecular drainage. And one of the important side effect of this medicine is corneal verticillata. So one of the important side effect of drug is corneal verticillata. This is the drug that is, yes, vortex keratopathy. We also call it vortex keratopathy, corneal verticillata. So this is the side effect caused by the drug netarsudil. So netarsudil, pilocarpine are the two medicines which can increase trabecular drainage. Now the medicine that can increase uveosteral drainage, this is the prostaglandin F2 alpha analog. So prostaglandin F2 alpha analog, the drug name is latanoprost. So latanoprost is a medicine that can increase uveosteral drainage, and this is overall considered as drug of choice for maintenance treatment of glaucoma. This is overall considered as best medicine for maintenance treatment of glaucoma. Drug name is latanoprost. Now, latanoprost is a drug when given to a patient. This medicine can lead to side effects, which we can remember with the mnemonic. The mnemonic is latanoprost, right? So, with the help of this mnemonic, latanoprost, we can remember the medicine side effect. So, what are the side effects of this medicine? Now, this medicine can increase the length of eyelashes. This medicine can increase the length of eyelashes. This medicine can result in tanning of iris. This medicine can result in tanning of iris. So the iris color will change to brown. So tanning of iris. Now this medicine can also cause edema in macula. So medicine can cause edema in macula. Now this medicine is pro-inflammatory drug. This medicine is a pro-inflammatory medicine, and because it's a pro-inflammatory medicine and acts on uvea and sclera. Acts on uvea and sclera. You can see uveoscleral drainage. So it will cause uveitis and scleritis. It will cause inflammation of uvea, that is uveitis, and sclera, that is scleritis. So this will cause uveitis and scleritis as a side effect. Right? Now, S means, thanks Dr. Kaushiki. Thanks for this compliment. S stands for sulcus. Now, this medicine can cause deep upper eyelid sulcus. This medicine can make the sulcus deep. So, deep upper eyelid sulcus, side effect of this medicine. So, deep upper eyelid sulcus is a side effect of this medicine, right? So, medicine side effects are increased length of eyelashes, tanning of iris. O stands for edema in macula. So, edema of macula. Pro means pro-inflammatory, uveitis and scleritis, and S means sulcus. This will make the upper eyelid sulcus deep. Right? Now come to the medicines which will decrease aqueous humor synthesis. So which medicine can decrease aqueous humor synthesis? Number one, medicine is like beta blockers. So beta blockers, the drug name is like timolol. So timolol is a medicine. This is a second drug of choice. This is a second drug of choice for maintenance treatment of glaucoma. This is a second drug of choice for maintenance treatment of glaucoma. So latanoprost is drug of choice. Latanoprost is drug of choice. Timolol is a second drug of choice. And the important side effect of timolol is this medicine can reduce the corneal sensitivity. This medicine can reduce the corneal sensitivity. So there is a risk of corneal ulcer, and this can also cause nasolacrimal duct blockage. This can also cause nasolacrimal duct blockage as a side effect. So this will reduce the corneal sensitivity, can result in nasolacrimal duct blockage, and this timolol should not be given to a patient of bronchial asthma and COPD. So this should not be given in patients of bronchial asthma and COPD. The drug name is timolol. Now, number two, in cases of bronchial asthma and COPD, we give the other beta blocker, betoxolol. So betoxolol is a beta blocker. This is given, but timolol is contraindicated in bronchial asthma and COPD. The second is medicine that will act on alpha-2 receptor. Medicine that will act on alpha 2 receptor, drug name is brimonidine. So brimonidine is a drug that can be given for the treatment of glaucoma. This will reduce the aqueous humor synthesis. Drug name is brimonidine. Now, brimonidine is a drug. It starts from alphabet B. So this should not be given to babies. This medicine should not be given to babies because this medicine can suppress the CNS center, including the respiratory center. So this medicine can suppress the neonate respiratory center. So should not be given to babies. Now the medicine is having the word R. Now R stands for its side effect. The important side effect of this medicine is retraction of eyelid. So one of the important side effect of medicine is retraction of eyelid, right? So retraction of eyelid is important side effect that starts from alphabet R. So B stands for babies, contraindicated. R means retraction of eyelid, and the I means inhibition of CNS. I means inhibition of central nervous system. So these two are side effect of this medicine, brimonidine. Right? So retraction of eyelid, inhibition of CNS, these are side effect of this medicine, brimonidine. Now after this brimonidine, guys, we have a next medicine that will reduce aqueous humor synthesis. Drug name is carbonic anhydrase inhibitors. Now we have a drug carbonic anhydrase inhibitor. So drug name is acetazolamide. Drug name is acetazolamide, which can be given by IV route, can be given by oral route. Can be given by IV route or oral route, and it's a first drug. It's a first drug to be given in patients of acute angle closure glaucoma. It is a first drug to be given in patients of acute angle closure glaucoma. So acetazolamide is a first medicine to be given in patients of acute angle closure glaucoma. It is given by IV or the oral route along with pilocarpine. So pilocarpine eye drops we give. So along with pilocarpine, this is the first medicine to be given in patients of acute angle closure glaucoma. Now the fourth medicine, sorry, please make a correction here. Now, apart from acetazolamide, we have some eye drops also. We have some eye drops also like brinzolamide and dorzolamide. So brinzolamide, dorzolamide are two eye drops which are carbonic anhydrase inhibitor, can be given to this patient, brinzolamide and dorzolamide. Now apart from that, we have a drug mannitol. So mannitol is one more medicine that is given by IV route. So mannitol is one more medicine that is given by IV route. This is also given for acute cases of angle closure glaucoma. This is also given for acute cases of angle closure glaucoma. So mannitol is given for acute cases of angle closure glaucoma. So it is given by IV route, right? So these are the drugs that we have covered under this topic of anti-glaucoma drug. Now, anti-glaucoma drug is very important topic for your exam. Like every year, you can expect one MCQ from this topic, that is anti-glaucoma drugs. Now, after this anti-glaucoma drugs, guys, let's talk about some diuretics. So diuretics which are given for edema. So which diuretics are given for edema, guys? Anyone would like to answer? Cerebral edema. For cerebral edema, which medicine would you like to mark? For cerebral edema, please remember, for cerebral edema, treatment of choice, if they will ask you, it's 3% saline. So treatment of choice is 3% saline, right? If they will ask you what is the drug of choice, you will mark mannitol. You will mark mannitol. Second drug, you will mark furosemide. So mannitol, furosemide, you will mark as the first and the second drug for cerebral edema. Very good. So for cerebral edema, 3% saline or the hypertonic saline. We also call it hypertonic saline. So hypertonic saline, 3% saline is the best treatment for cerebral edema. And the drug of choice, if they will ask you, is mannitol. The second is furosemide. Now, which medicine we can use for raised ICT? Now, if they will ask you which medicine we use for raised ICT, so the medicines that are given for raised ICT, again the drug of choice is mannitol. Again the drug of choice is mannitol, but the second drug of choice you will mark as acetazolamide. So mannitol is a first drug of choice. Second drug of choice is acetazolamide. First is mannitol, second drug of choice acetazolamide. So guys, you have noticed one thing. Whenever the problem present in CNS, so in CNS problem, mannitol is the preferred diuretic. But whenever the patient will have the raised intraocular pressure, like we people have already covered, acetazolamide. So acetazolamide is given along with pilocarpine eye drops. So acetazolamide is given along with pilocarpine eye drops in treatment of acute angle closure glaucoma. So in treatment of acute angle closure glaucoma, acetazolamide is given along with pilocarpine eye drops. Now, which drug we can use for CHF with pulmonary edema? So CHF with pulmonary edema, guys, please remember, drug of choice is furosemide. So drug of choice is furosemide for CHF with pulmonary edema. But if the symptoms are not controlled, if the symptoms are not controlled, we will add thiazides. We will add thiazides in the patient treatment. And there is one thiazide that we can add is known as metolazone. Metolazone. So metolazone is a name of a thiazide that we can add in the patient treatment. Right? So furosemide is the best medicine for congestive heart failure with pulmonary edema. If the disease is not controlled, we will add thiazides. We will add thiazide in the patient treatment where metolazone is a drug that is used. If the question is asked to you, what is the best medicine for liver cirrhosis ascites? So best medicine for liver cirrhosis ascites, the answer is spironolactone. So spironolactone is the best medicine for liver cirrhosis ascites. Now, if the question is asked to you, which is the best medicine for CKD? CKD with periorbital edema. So CKD with periorbital edema, guys, you will mark furosemide. So furosemide is the drug of choice in CKD associated with periorbital edema. Now we have the pedal edema. For pedal edema, again, guys, you will mark loop diuretics. So loop diuretics are the medicines which are useful, but any of the drug you can mark. You can mark furosemide. You can also mark torsemide. Totally depends upon you. So these are the drug of choice for different types of edema. We have talked about cerebral edema. We talked about cerebral edema, raised ICT, raised intraocular pressure, CHF with pulmonary edema, liver cirrhosis ascites, CKD with periorbital edema, and the pedal edema. All we have covered in this. Yes, loop diuretics, sulfa allergy can occur. Loop diuretic sulfa allergy can occur, but Dr. Muhammad, uh, the loop diuretics are not very strong sulfa drugs. So studies have shown like loop diuretics, thiazide diuretics, although they have some component of sulfa, but patient will generally do not get hypersensitivity. Like rarely the patient will get hypersensitivity due to loop diuretics and thiazide diuretics. So this is not an issue, right? So this is not an issue. Clinically, the people don't face this problem of sulfa allergy with loop diuretic and thiazide diuretics as per the clinical trials. I'm not talking about my own clinical experience. This is given in the textbooks that the allergy caused by loop diuretic and thiazide diuretic is not clinically significant. Brinzolamide, drug of choice in children. Children, no, Dr. Siddharth, children if congenital glaucoma you want to know, so congenital glaucoma we can give latanoprost. Latanoprost we can give in congenital glaucoma. There's no harm. In congenital glaucoma we can give latanoprost for maintenance, and we can manage the acute patient with pilocarpine plus acetazolamide. Any doubt apart from these doubts which you people have asked? Okay. Now come to the medicines. Now come to the diuretics that will act on PCT of kidney. So diuretics that will act on PCT of kidney. So diuretics that will act on PCT of kidney. So please remember, medicines are carbonic anhydrase inhibitors. Medicines are carbonic anhydrase inhibitors. Medicines are osmotic diuretics. Osmotic diuretics, and the drugs are SGLT2 inhibitors. And in the topic of kidney, this is the most important topic for your exam. This is the most important topic for your exam, the medicines that will act on PCT of kidney. So the medicines which are carbonic anhydrase inhibitor, drugs are acetazolamide, brinzolamide, dorzolamide that we have covered. Acetazolamide is available oral and IV. Brinzolamide, dorzolamide are eye drops. And we people have already covered. These medicines are given as a drug of choice. These medicines can be given as a drug of choice for acute angle closure glaucoma along with pilocarpine, and they are also given as a drug of choice for acute mountain sickness. So acute mountain sickness, and acute angle closure glaucoma, acetazolamide. I'm talking about acetazolamide. This is given as a drug of choice for acute angle closure glaucoma as well as for acute mountain sickness. Now, acetazolamide is second drug of choice we have already covered above. It's a second drug of choice for raised ICT. This is a second drug of choice for raised ICT we have already covered above. Now, one of the important side effects of acetazolamide is metabolic acidosis. So, one of the important side effects is metabolic acidosis. Hyperchlorhydemia can result in formation of kidney stones, and one more side effect is hypokalemia. So, four important side effects are metabolic acidosis, hyperchlorhydemia, hypokalemia, and kidney stone formation. These are the side effects of acetazolamide. So medicine can cause metabolic acidosis, hyperchlorhydemia, hypokalemia, and renal stone formation. Now the second drug is mannitol. Now mannitol is a drug. This is given by IV route. This is the medicine that is given by IV route. Mostly we use the 20% solution. Mostly we use 20% solution of mannitol. So mostly we use 20% solution of mannitol, and this is the medicine that will retain the water in plasma. So this is the medicine that will increase the plasma volume. So mannitol is a osmotic diuretic. This is given to increase the plasma volume. So guys, in which condition we want to increase the plasma volume? So we have to increase the plasma volume because the medicine mannitol, when given by IV route, it will remain in the plasma. This will pull the fluid from the tissues. This will increase the plasma volume. So we want to increase the plasma volume. We want to pull the water from the tissues, and we can shift the fluid to the plasma in conditions like we have discussed cerebral edema. So in cerebral edema, we can pull the fluid from the tissues. In patients of raised ICT, we don't want to make the cerebrospinal fluid, as well as in patients of post dialysis. In patients of post dialysis disequilibrium syndrome. So in patients of post dialysis disequilibrium syndrome, this is a drug of choice. So this medicine can retain the fluid in the plasma. This will retain the water in the plasma. So this can pull the water from the tissues. It's a drug of choice for cerebral edema, drug of choice for raised ICT, also drug of choice for post dialysis disequilibrium syndrome. Now guys, this medicine is contraindicated in those scenarios where the plasma volume is already high. So in which conditions plasma volume is already high? So medicine is contraindicated where the plasma volume is already high. So plasma volume is already high in conditions like CHF with pulmonary edema. So this should not be given to a patient with CHF with pulmonary edema in patients of end stage renal disease. In patients of end stage renal disease, because the GFR is low. Because the GFR is low, already the plasma volume is high, so this medicine should not be used. So in patients of end-stage kidney disease, CHF with pulmonary edema, this is contraindicated. Now, we have the medicines which are SGLT2 inhibitors. Medicines which are SGLT2 inhibitor, the full form is sodium glucose linked transporter 2 inhibitors. Sodium glucose linked transporter 2 inhibitors. Right? Now, all these medicines end with the word gliflozin. All these medicines end with the word gliflozins. Now, whenever we give these medicines to a patient, these medicines can cause loss of sodium and water. Medicines can result in loss of sodium and water from the body. So these medicines can decrease the plasma volume. These medicines can decrease the plasma volume. So we can use this medicine for congestive heart failure. So we have two medicines, empagliflozin, dapagliflozin. So empagliflozin, dapagliflozin are two medicines. They are given for congestive heart failure. So these medicines can decrease the plasma volume. Medicines are given for congestive heart failure, empagliflozin, dapagliflozin. Now these medicines can also result in increased loss of glucose. Medicine can result in increased loss of glucose from the urine or from the kidney. So medicines are also given for diabetes mellitus 2. Medicines are also given for diabetes mellitus 2. Now these medicines can reduce the risk of microangiopathy. So in diabetic patients, medicines can reduce the risk of microangiopathy. So in diabetic patients, these medicines can reduce the risk of microangiopathy. So they can reduce the risk of coronary artery disease. These medicines can reduce the risk of coronary artery disease. Apart from that, guys, these medicines are considered as second drug of choice. Second drug of choice for proteinuria. So these medicines are second drug of choice for proteinuria. So for proteinuria, these medicines are the second drug of choice. Guys, give me 1 minute. There is some charging issue at my end. Okay. Yes. So these medicines are second drug of choice for diabetic nephropathy or diabetic kidney disease or proteinuria. Now, guys, what are the side effects of these medicines? What are the side effects and contraindications of these drugs? So these medicines can cause loss of sodium and water. And because of this loss of sodium and water, these medicines can cause dehydration as a side effect. These medicines can decrease the GFR of the patient. Medicines can cause dehydration. Medicines can decrease the GFR. And for the same reason, all these medicines are contraindicated when the patient GFR is already less than 30 to 45. When the patient GFR is less than 30 to 45, these medicines are contraindicated. But empagliflozin is a medicine this can be used. So empagliflozin is a medicine that can be used even if GFR is low. So this is the AIMS question this year, November AIMS. So empagliflozin can be used even if the GFR is low. So medicines can cause dehydration, medicines can reduce the GFR, medicines can cause orthostatic hypotension. So because of loss of sodium and water, patient can have the orthostatic hypotension. Because of that reason, patient can fall. And when the patient will fall, patient can have the bone fracture. Patient can have the bone fracture when the patient will fall. So this is the problem, bone fracture, which can occur with these medicines. Now, the second side effect is the medicines can cause glycosuria. Now, because of this spontaneous glycosuria, as you people have already mentioned, these medicines can cause UTI. So, very commonly, these medicines can cause candidiasis. Medicines can cause candidiasis as a side effect. Medicine can cause genital skin infection. Medicines can cause genital skin problem like Fournier's gangrene can occur. In females, vulvovaginitis can occur. So in females, vulvovaginitis can occur, Fournier's gangrene can occur, and patient can have the weight loss. The fourth side effect is patient can have the weight loss. So because of continuous loss of glucose, patient can have the weight loss, UTI, Fournier's gangrene, vulvovaginitis, all these are side effects of this medicine. Right. Dr. HM, empagliflozin is the one that is contraindicated when the GFR is less than 15. Empagliflozin is contraindicated when the GFR is less than 15. Right? So empagliflozin is the only drug which has the liberty to be given even up till the last stage of kidney disease. Now guys, very important side effect of this medicine, they can increase the risk of limb amputation. So these medicines can increase the risk of limb amputation. So should not be given in patients of peripheral vascular disease or the patients who have diabetic foot ulcers. So in patients of diabetic foot ulcers and peripheral vascular disease. So medicines can increase the risk of limb amputation, should not be given in patients of peripheral vascular disease and diabetic foot ulcers. And the fourth side effect is these medicines can increase the risk of DKA. Medicines can increase the risk of diabetic ketoacidosis. Now, because of this increased risk of diabetic ketoacidosis, these medicines are contraindicated. Contraindicated in diabetes mellitus 1 patients. So, in diabetes mellitus 1 patients, medicines are contraindicated. So, in patients of diabetes mellitus 1, they are contraindicated because they can increase the risk of diabetic ketoacidosis. So, in diabetes mellitus 1, they are contraindicated. Yes, all these problems are maximally associated with canagliflozin. All these medicines maximally associated with canagliflozin. So canagliflozin, Dr. Kirat Meet Singh has given the correct answer. Canagliflozin is a medicine. All the problems, whatever we have discussed, like limb amputation. Similarly, like we have discussed the bone fractures, we have covered about the bone fractures above. So bone fractures, limb amputation, all these problems are more commonly seen with canagliflozin as a drug. It is maximally seen with canagliflozin as a drug. So this group is very, very important for the exam. This is medicines that will act on PCT of kidney. One MCQ is confirmed from this topic, right? This is very important. Now we have some unimportant topics. Unimportant topics in kidney like loop diuretics and thiazide diuretics. So if we talk about loop diuretics and thiazide diuretics, loop diuretics site of action is ascending loop of Henle. Ascending loop of Henle is a site of action. No, MS thyroid medullary cancer नहीं होगा. There's no risk of thyroid medullary cancer, right? Ascending loop of Henle is a site of action of loop diuretics. Thiazide diuretics will act on early DCT. Thiazide diuretics will act on early DCT. Now, loop diuretics, Dr. Sahal, diabetic ketoacidosis कैसे करते हैं? Dr. Sahal, these medicines will only remove the glucose from your body, right? So diabetic patients में, if you want to treat a diabetic patient, there should be two approaches. One approach is either you have to increase insulin or you have to decrease the insulin resistance. The main problem in diabetes is the insulin is not present, or the second problem is there is insulin resistance. So whenever we have to treat diabetes, there are two options. One, we can increase insulin or we can decrease uh, the insulin resistance. But these medicines are removing the glucose. So by removing the glucose, you are not treating the disease. You are just giving a relief in the laboratory parameter. So when you decrease the glucose in the plasma, you only decrease the laboratory parameter. So your blood glucose level will go down, but your disease is not controlled. So as a result of that, guys, what will happen? When your glucose level will go down, so patient automatically start reducing the less dose of other anti-diabetic like insulin. So the patient will start taking the less dose of insulin because his blood glucose level is low. If he will take the high dose, then he will get the hypoglycemia. So patient who is taking high dose of insulin, now he will start taking low dose of insulin because of less glucose, and now he can end up in diabetic ketoacidosis because his disease is actually not treated, but he has reduced the dose of insulin, so decay risk is increased, so contraindicated in diabetes mellitus 1. How the carbonic anhydrase inhibitor causes hypokalemia. Uh, Carbonic anhydrase inhibitors can result in loss of bicarbonate, and because of this bicarbonate loss, body has to compensate. So how body will compensate? Body will retain chloride because it's a negative charge. Body will retain chloride, so hyperchloridemia, or body will lose the positive charge that can be potassium. So body will retain chloride or body will retain potassium. This is how the medicines will cause hyperchloridemia and hypokalemia. Carbonic anhydrase inhibitors. So we are discussing loop diuretic, thiazide diuretic. Answers fast because these are the easy topics. So loop diuretics will act on ascending loop of Henle. What is the mechanism of action? Mechanism of action, they are inhibitor of sodium chloride pump. Sodium potassium dichloride pump. Thiazide diuretics are inhibitor of only sodium chloride pump. So thiazide diuretics will act on early DCT. They are inhibitor of only sodium chloride pump. Now loop diuretics are the medicines. They will cause 20% of sodium and the water loss. These medicines are the medicines which are most efficient. They are the most efficient diuretics available in the market. High efficiency diuretic. They will cause 20% of sodium and water loss. But these medicines can cause only 5 to 10% of sodium loss. These medicines will cause only 5 to 10% of sodium loss, but there is no loss of water. So medicines will not cause loss of water. Only 5 to 10% of sodium is lost. So they are the medium efficacy. So their efficacy is medium. Their efficacy is medium. If we talk about the ceiling effect, they are the high ceiling diuretics and they are the low ceiling diuretics. So thiazides are the low ceiling diuretics. Now these medicines are given for treatment of hypertension associated with comorbidity. So they are given for hypertension that is always associated with comorbidity. So they are given for hypertension associated with comorbidity, like they are given for hypertension associated with CHF. They are given for hypertension associated with CKD. So they are given for hypertension with comorbidity like CHF or CKD. Now these medicines are given for hypertension mostly without comorbidity. So mostly these medicines are given for hypertension without comorbidity and they are the first line drugs. They are the first line drugs for maintenance treatment of hypertension without comorbidity. So first line drugs for maintenance treatment of hypertension without comorbidity. Now, these medicines can cause loss of calcium. These medicines can cause loss of calcium. So, medicine is given for hypercalcemia. So, loop diuretics are given for hypercalcemia. But thiazide diuretics retain calcium. Thiazide diuretics retain calcium with the action of parathyroid hormone. So, with the action of parathyroid hormone, they retain calcium. And because they retain calcium, they are given for the treatment of hypocalcemia. They are given for the treatment of hypocalcemia, right? Now, effect on the body water. Now, these medicines can cause loss of body water, and therefore these medicines are given for the treatment of edema. They are given for the treatment of edema, like they are the drug of choice for CHF edema. They are the drug of choice for CKD edema. They are also drug of choice for pedal edema. They are drug of choice for pedal edema. Now, these medicines will cause retention of water. Thiazides will cause retention of water, and they are the drug of choice for nephrogenic diabetes insipidus. They are the drug of choice for nephrogenic diabetes insipidus, right? So they're just opposite to each other. You can see from here, like if we talk about hypertension, loop diuretics are given for hypertension with comorbidity. Thiazides are given for hypertension without comorbidity. These medicines can cause loss of calcium. These medicines will cause retention of calcium. Loop diuretics will cause loss of water. These medicines will cause retention of water. So as a result of that, they have the totally opposite indication. They have totally opposite indications that we have covered, right? Apart from the other properties, they are the high ceiling drugs. These are the low ceiling drugs. Efficacy में loop diuretics are more efficacious. Thiazides are less efficacious. Mechanism of action, they are blocker of sodium potassium dichloride. Thiazides are inhibitor of sodium chloride. Loop diuretics will act on ascending limb of Henle. Thiazides will act on early DCD. So these are the difference between loop diuretics and the thiazide diuretics. Now guys, after that we can discuss the medicine side effects. So whenever we talk about the side effects, these medicines can cause loss of all ions from the body. These medicines will cause loss of all ions from the body, but there is no loss of calcium by thiazides. So these medicines can cause loss of all ions from the body, but there is no loss of calcium by thiazides. Now these medicines can affect all nerve conduction in the body. So these medicines can affect all the nerve conduction in the body. So medicines can cause sensory and the motor neuropathy. So these medicines can cause sensory and the motor neurotoxicity. Apart from that, these medicines can affect all the metabolic pathways of the body. So all the metabolic pathways of the body have the negative impact, right? So these medicines can cause loss of all ions, but there is no loss of calcium by thiazides. Medicines can cause all nerve conduction get disturbed because of loss of ions, and these medicines can affect the all metabolic pathways. So when these medicines affect the metabolic pathways, medicines can cause hyperglycemia, medicines can cause hyperlipidemia, medicines can also cause hyperuricemia. So drug can cause hyperglycemia, hyperlipidemia, hyperuricemia. Yes. So all ions are lost, all nerve conduction get affected, and all metabolic pathways get affected. Side effect of loop diuretics and thiazide diuretics that we have covered. Right? So thiazide diuretics, loop diuretics we have covered. Now let's move on to the other medicines like the potassium sparing diuretics. So if we talk about the medicines which are potassium sparing diuretics, so potassium sparing diuretics, medicines names are spironolactone, medicines are eplerenone, medicines are finrenone, medicines are amiloride. So medicines which are potassium sparing diuretics, spironolactone, eplerenone, finrenone, amiloride. Now, because they are potassium sparing diuretics, most important side effect is hyperkalemia. And because of hyperkalemia, they should not be given in patients of CKD. And they should also be avoided with AC inhibitor and ARB because AC inhibitor, ARB, their side effect is also hyperkalemia. AC inhibitor, ARB, their side effect is also hyperkalemia, so they are contraindicated with them. Now, spironolactone is a medicine. This is given for hypertension. So, it is given for resistant hypertension. It is a drug of choice for Pons syndrome. Spironolactone is a drug of choice for Pons syndrome where the aldosterone level is high. Now, spironolactone is also given for hirsutism because this medicine can inhibit the testosterone in female body. So in female body, this can inhibit the testosterone effect. So it is given for hirsutism. It is a drug of choice for Conn's syndrome, where the aldosterone level is high. It is also given for resistant hypertension. Now, eplerenone is a drug. It is given for congestive heart failure. Now, why it is given for congestive heart failure? Because it can prevent cardiac remodeling. So, this is inhibitor of the renin-angiotensin-aldosterone pathway. So, by inhibiting renin-angiotensin-aldosterone pathway, right? So, by inhibiting renin-angiotensin-aldosterone pathway, medicine can reduce the cardiac remodeling. And if you reduce the cardiac remodeling, you can overall reduce the mortality in CHF. So, these medicines can reduce the mortality, overall improve the survival in patients of CHF. So, eplerenone is a drug. This is given for CHF. Now, guys, finrenone is a drug. It is a third drug of choice. It is a third drug of choice for diabetic kidney disease, right? So we have discussed that second drug of choice. Second drug of choice for diabetic kidney disease is SGLT2 inhibitors. So diabetic nephropathy, second drug of choice, SGLT2 inhibitors. Third drug of choice, finrenone. But if the question is asked to you, what is the drug of choice? The drug of choice is AC inhibitor ARBs. So AC inhibitor ARBs are the drug of choice for diabetic nephropathy or diabetic kidney disease. Now we have the drug amiloride. Now amiloride is a medicine which is inhibitor of epithelial sodium channel. So by inhibiting epithelial sodium channel, it is a drug of choice for Liddle's syndrome. It is a drug of choice for Liddle's syndrome, as well as it is a drug of choice for lithium induced polyuria. It is a drug of choice for lithium induced polyuria and drug of choice for Liddle syndrome. Yes, Dr. Potato has mentioned that spironolactone is also drug of choice for ascites. It is also drug of choice for ascites that we have already covered above. So treatment of edema that we have also covered above. So it is also a drug of choice for ascites. So these are the various indications of potassium sparing diuretics. So potassium sparing diuretics indications we people have covered. Indications, side effects, contraindication, everything we people have covered. Right? Now, guys, we have some electrolyte imbalance. So, in electrolyte imbalance, there are three important ions: sodium, calcium, and potassium. Three important ions: sodium, calcium, and potassium. So, we have hypernatremia, hyponatremia. Similarly, we have hypercalcemia, hypocalcemia. So, we have hyperkalemia, hypokalemia. So, what is the treatment for hypernatremia? So, whenever we say the patient's sodium level is high, whenever we say sodium level is high, it means there is a loss of water. So, there is a loss of water that has taken place, and because of the loss of water, patient has got hyperkalemia. Right? So, patient has got hyperkalemia. Sorry, patient has got hypernatremia because the water is lost from the body. Now, guys, why the water is lost? Why the water is lost from the body? Because of the diabetes insipidus. So, diabetes insipidus is a condition where the antidiuretic hormone action is gone. So, action of antidiuretic hormone is gone. That is known as diabetes insipidus. Loss of water will take place, and this will cause hypernatremia. Right? Now, for this hypernatremia, we have to dilute. We have to dilute the sodium. So, how we can dilute the sodium? So, we can dilute the sodium by telling the patient to have the more fluid intake. So, in a stable patient, we tell the patient for fluid intake, but in unstable patients, in stable patient, we tell the patient to consume oral fluid, but in unstable patient, we go for hypotonic saline. In unstable patient, we go for hypotonic saline. In stable patient, we tell the patient for the fluid intake. Now, for central diabetes insipidus, guys, desmopressin is a drug of choice. Desmopressin is ADH analog. It is a drug of choice. But for nephrogenic diabetes insipidus, we have covered thiazides are drug of choice. Right? This is the hypernatremia. Now, which medicines we can use for hyponatremia? Now, hyponatremia means sodium level is low. Now, why the sodium level is low? Because there is a excessive water that is present in the body. So, body has to lose water and sodium both. So patient will have the hyponatremia because of the excessive antidiuretic hormone. So here we do the opposite. Like in previous case, we have discussed that we tell the patient to have the more fluid. Here we tell the patient to go for fluid restriction. We tell the patient like the patient is stable, fluid restriction. Patient is unstable, we will give hypertonic saline. Now the drug of choice. Drug of choice is tolvaptan. Right? So drug of choice for this condition is tolvaptan that we can use in patients of SIADH. Also, the other name is hyponatremia. Now, if we talk about, yes, tolvaptan is vasopressin 2 blocker. Okay, so guys, if I'll go itna slow to fit, I mean, how will we able to finish the course? I have to then jump from the topics. So totally up to you. Like, I wanted to cover all topics, so no problem. Like, in case you want me to go a bit slow, so I can slow down the speed also. So hypercalcemia. So if I talk about hypercalcemia, so guys, most of the time, patient of hypercalcemia, there is a dehydration also present. So in patients of hypercalcemia, dehydration also present. So first is mild hypercalcemia. Patients who have mild hypercalcemia. So mild hypercalcemia, serum calcium level is less than 12 or patient is asymptomatic. So only the conservative treatment is given. So only the conservative treatment is given, but you should avoid the dehydration. You should avoid the dehydration, right? So you should avoid the dehydration in this mild hypocalcemia. Now, moderate hypercalcemia, when the serum calcium level becomes 12 to 14. So initially we discussed less than 12, now 12 to 14. Now, apart from the above advice, the drug of choice is bisphosphonates. Bisphosphonates are the drug of choice. Bisphosphonates are the medicines which are the drug of choice for moderate hypercalcemia. But in severe hypercalcemia, when the serum calcium level becomes more than 14, then we go for IV bisphosphonates. We go for IV bisphosphonates as the drug of choice. Plus, we will give hydration therapy. We will give hydration therapy because this patient is dehydrated. So in dehydration, we have to give isotonic saline. Now, when we give isotonic saline for dehydration, there is a risk of uh, hypervolemia also there. Plus, guys, you must be knowing furosemide is a drug that will also cause increased loss of calcium. So when we want the fast action, along with IV bisphosphonates, I will give furosemide. So along with IV bisphosphonate, I will give furosemide, and furosemide can further cause more dehydration. Furosemide can also cause more dehydration, so isotonic saline is very, very important here in severe hypercalcemia. Apart from that, we have some other drugs like calcitonin can be given, denosumab dialysis can also be done. So other medicines you can read by yourself from these notes. Now in the treatment of hypocalcemia, we will give the calcium supplements. So in hypocalcemia, we will go for calcium supplements. So hypocalcemia, we can go for uh, calcium supplements. So calcium supplements can be given by oral route like calcium carbonate and all. And IV route, we'll give calcium gluconate, right? So this is how we treat hypocalcemia, right? Then we have the potassium. So we talk about the potassium level. We have hyperkalemia and we have hypokalemia. We have hyperkalemia, hypokalemia. Now for hyperkalemia, guys, calcium gluconate is a drug of choice. Calcium gluconate is a drug of choice if the patient is getting ECG changes or the potassium level has become more than 6.5. But otherwise, if there is no ECG change, insulin plus glucose therapy, I mean the DNS, you can write down instead of glucose. So insulin plus DNS. Insulin plus DNS is the first line treatment. So insulin plus DNS is a first line treatment in hypokalemia if there is no ECG changes. We can also give loop diuretics because loop diuretics will also cause loss of potassium. So loop diuretics will also cause loss of potassium. We can also go for hemodialysis if there is a ESRD, and potassium binding agents can also be tried. Now for hypokalemia, things are very easy. We can give pot chlor. So pot chlor, potassium chloride is a drug of choice. This can be given by oral route, can be given by IV route. This is how we manage this electrolyte imbalance. So we have discussed the treatment of all three electrolytes which are important for the exam. Sodium, calcium, and potassium we have covered, right? Now after that, guys, we have a next topic, cardiovascular system. So in cardiovascular system, we have a topic antihypertensive drugs. So antihypertensive drugs, very, very important topic for your exam. Like you people will definitely get question out of it. Yes, Dr. Susika Mushi, we can give regular insulin here. We can give regular insulin over here to the patient. So regular insulin can be given, or if you want to change the insulin, you can go to rapid acting insulins. So rapid acting insulins or regular insulins are given, right? Because you want the fast action. So these medicines are preferred. Okay, so if we talk about diuretics, so antihypertensives. So which medicines are used as antihypertensives? So antihypertensives that we can use, the first is diuretics. So diuretics can be given for hypertension. So guys, we have already covered thiazides are the first line drugs. Thiazides are the first line drugs for hypertension, maintenance treatment of hypertension without comorbidity. So first line drugs for the hypertension without comorbidity, we can use the thiazides, and these two thiazides are preferred. So chlorthalidone and indapamide, right? किसमें डॉक्टर चारुलता मैग्नीशियम in hypocalcemia you have to treat hypomagnesemia also. Yes, beta 2 agonist can also be given. In hyperkalemia, guys, please add on one more drug. So Dr. Shubhangi, nahi, Dr. HM has mentioned that there is a sixth medicine also, salbutamol. So salbutamol is beta 2 agonist, can be given, right? So actually insulin and salbutamol, they act by same mechanism. Insulin and salbutamol, they act by the same mechanism to reduce the potassium. So Dr. HM, basically what happens when we have already given insulin, so salbutamol has limited role after that, because we never give two medicines of same mechanism together. So insulin, no doubt, salbutamol is one of the very important drug for hyperkalemia. So it's thanks for reminding us that we have missed the salbutamol in the list. But generally, I'm telling you, like insulin and salbutamol, they act by the same mechanism. So if you have already given insulin, then salbutamol has limited role after that, right? So if we talk about hypertension, chlorthalidone and indapamide are the medicines which are preferred. Why these medicines are preferred? Because they have the minimum metabolic side effect. So among all thiazide diuretics, they have the minimum metabolic side effect. Plus these medicines are also the long acting drugs. So patient compliance is very good. So chlorthalidone, indapamide, they have the minimum metabolic side effect, plus they have the long action. So they are the first line drugs, most preferred thiazides in treatment of hypertension without comorbidity. Now the medicines like loop diuretics, drug name is furosemide. Now this is given for hypertension with comorbidity. I have already told you it is given for hypertension with CHF, hypertension with CKD, right? So in patients of hypertension with CHF and CKD, this is the medicine that we can use. Now, spironolactone is a medicine. This is given for resistant hypertension. This is given for the treatment of resistant hypertension, and we have already covered the side effect of medicine is hyperkalemia. Side effect of this medicine is hyperkalemia. Spironolactone is given for resistant hypertension. The first group of medicine given for hypertension: thiazides, loop diuretics, and potassium-sparing diuretics. Then we have the medicines ANS drugs, right? So medicines that will act on autonomic system. So these medicines are also given for hypertension. So we people have already covered. Prazosin is given particularly in the treatment of hypertension. It is particularly given for the treatment of hypertension, which is also associated with scorpion sting. So hypertension associated with scorpion sting, prazosin is given. Now phentolamine is drug of choice. Phentolamine is a drug of choice for hypertension crisis. Hypertension crisis associated with cheese reaction as well as clonidine withdrawal syndrome. It is a drug of choice for hypertension crisis associated with cheese reaction and clonidine withdrawal syndrome. So clonidine withdrawal syndrome and cheese reaction, two indications starts from C. We use phentolamine. Now phenoxybenzamine we have already covered. It is given for hypertension associated with pheochromocytoma. It's a drug of choice for hypertension associated with pheochromocytoma. So this we people have already covered. Now If we talk about beta blockers, labetalol is a drug of choice for PIH. It's a drug of choice for pregnancy-induced hypertension. And ismolol is a drug. This is given along with nitroprusside. This is given along with nitroprusside as a drug of choice for hypertension crisis associated with aortic dissection. So hypertension crisis associated with aortic dissection, ismolol plus nitroprusside are given together. So ismolol plus nitroprusside given together in treatment of hypertension crisis with aortic dissection. Now we have the medicine like clonidine. Now clonidine is a drug which is given for hypertension associated with CKD. So this can be given for treatment of hypertension associated with CKD. But one of the important side effect of this medicine is this is the medicine associated with rebound hypertension crisis. So this is the drug associated with rebound hypertension crisis. So this medicine is associated with rebound hypertension crisis. Now, alpha methyl dopa is a drug which is given for PIH. This medicine is given for PIH. They both medicines will act on alpha 2 receptor, alpha methyl dopa and clonidine. So, alpha methyl dopa given for PIH. And one of the important side effect of this medicine is postpartum depression. So, postpartum depression is important side effect of alpha methyl dopa as a drug. Now we have the medicines that will act on renin, angiotensin, aldosterone system. Medicines which are blocker of renin, angiotensin, aldosterone system. Yes, Dr. HM, this will also cause SLE. Alpha methyl dopa will also cause SLE, but here in one short videos we are talking only about the major concern. ठीक है, तो alpha methyl dopa में we have the biggest concern about this postpartum depression, PPD, right? First dose phenomena seen with alpha blockers. So whenever we use alpha blockers, patient can have the hypotension in initial 1 or 2 days of therapy. So initial 1 or 2 days of therapy, patient can have the hypotension. That is first dose phenomena seen with alpha blockers. Now guys, the medicines which are renin angiotensin receptor blocker. So medicine is renin inhibitor. So the name of the drug is aliskiren, and only the name is enough. No need to remember anything else. So aliskiren is a drug which is a renin inhibitor. Now, all medicines which are AC inhibitor, they end with the word pril. So, all AC inhibitor ends with the pril, and all receptor blocker. So, all angiotensin receptor blocker, they end with the word sartan. So, angiotensin receptor blocker, they end with the word sartan, and AC inhibitor ends with the pril. Now, these medicines are the first line drugs for maintenance treatment of hypertension, especially in young patients. So, especially in young patients, they are the preferred antihypertensive drugs. They're also given for congestive heart failure. These medicines are also given for congestive heart failure. So in patients of congestive heart failure, these medicines are mainly given to prevent the cardiac remodeling. So in patients of congestive heart failure, these medicines are mainly given to prevent the cardiac remodeling. And we have already covered, they are the drug of choice for DKD. They are the drug of choice for DKD. Right? So diabetic kidney disease, they are the drug of choice. They're also given as first line drug. They're also given as first line drug for maintenance treatment of hypertension in young patients. And these medicines are also given for congestive heart failure to reduce the cardiac remodeling. Now, here there's a most important drug that I'm going to discuss now, which is very, very important for your exam, right? So, which drug will cause maximum reduction of mortality? So, by prevention of remodeling, the medicine can cause maximum reduction of mortality and the maximum improvement of survival. Maximum reduction of mortality, maximum improvement of survival that belongs to this class of medicine that is known as ARNI. So who will tell me the ARNI is a new medicine which is a combination of two drugs. So ARNI is a drug which is a combination of two drugs. So who will tell me this medicine is combination of which two medicine? So first is ARNI, second is AC inhibitor, third is angiotensin receptor blocker. So first is ARNI, second is AC inhibitor, angiotensin receptor blocker. This is the best medicine to reduce mortality and improve survival. So this is a combination of, very good. This is a combination of, no, it's not the combination of tell me certain. It's not tell me certain. Dr. Surbhi has given the correct answer. Surbhi, very good. Dr. Nishchay has given the correct answer. Very good. Rushabh, Komal. Komal, name batao drug ke. We want to know the names of the medicines. Yes, very good. Dr. Mamba, Dr. Chakna, Chakna Chor, Chakna Chur. Okay. I thought your name is Chakna Chor. In Hindi, the Chakna is, who will tell what is Chakna in Hindi? Okay, yes. So this is the combination of Valsartan. This is the combination of Valsartan plus sacubitril. This is a combination of Valsartan plus sacubitril, right? So combination of Valsartan plus sacubitril. This is Arni. It's an angiotensin receptor blocker, neprilysin enzyme inhibitor. So guys, here the Valsartan can cause hyperkalemia as a side effect, and sacubitril is a drug which can cause angioedema as a side effect. So sacubitril can cause angioedema and valsartan can cause hyperkalemia as a side effect. So this is very, very important drug for your exam, right? I mean, Siddharth, I wanted to know what is the significance of Chakna. I wanted to know Chakna ka significance. Why this Chakna is very important for us. Like his name is Chakna Chur. I thought his name is Chakna Chor. So hyperkalemia and angioedema, two important side effects of this ARNI. Rest of the details we'll discuss later on. Right. Okay, who will answer me this question? All AC inhibitor ARBs. All AC inhibitors and ARBs are prodrugs. All AC inhibitors ARBs are prodrugs except two medicines. So which two medicines are not prodrugs? Anyone would like to answer? So there are two medicines which are not prodrug. One is known as captopril. Second is known as lisinopril. So captopril and lisinopril are two medicines which are not prodrug. All medicines are prodrug. Now guys, all AC inhibitors and ARBs. All AC inhibitors and ARBs are unsafe in CKD. So please make a correction in your PDF. All AC inhibitor and ARBs are unsafe in CKD except one. Except one that you people have to remember. So all AC inhibitor ARBs are unsafe to use in CKD. Basically, we have to use them in low dose. So unsafe in CKD, so we have to reduce the dose of the medicine. We have to reduce the dose of the medicines in patients of CKD, except one drug that is known as telmisartan. So telmisartan is a drug which is purely metabolized by liver. It is purely metabolized by liver. For rest of the medicines, we have to reduce the dose. But telmisartan is a drug which is purely metabolized by liver. So it is safe to use in patients of CKD. Now, who will tell me which medicine has antiplatelet and uricose uric property? So the medicine which has antiplatelet and uricose uric property, this medicine is losartan. So losartan is a drug which has antiplatelet property. So this medicine has antiplatelet property by inhibiting thromboxane A2 receptor. So by inhibiting thromboxane A2, it has antiplatelet property. And losartan also has uricose uric property. Now, which ARB, which ARB is given for migraine? So the ARB that is given for migraine is candesartan. So candesartan is a ARB that is given for migraine. So candesartan is a ARB that is given for migraine. So candesartan is given for migraine. Now, who will tell me which ARB has anti-diabetic property? Which angiotensin receptor blocker has anti-diabetic property? So angiotensin receptor blocker which has anti-diabetic property, drug name is telmisartan. So telmisartan is a drug. Telmisartan is a medicine which has anti-diabetic property. Which has anti-diabetic property. Now if we talk about side effects and contraindications of AC inhibitor ARB. So guys, please remember, most common side effect is cough. Most common side effect is cough caused by AC inhibitors. So AC inhibitors are the medicines where the most common side effect of medicine is cough. Now this cough caused by this medicine is due to bradykinin. This cough is due to bradykinin. If we will not stop the medicine, patient can develop the complication as angioedema. So most common side effect is cough followed by angioedema. Now this is due to the bradykinin accumulation, and for the same reason we should not combine. We should not combine AC inhibitors along with sacubitril. So along with sacubitril, we never combine AC inhibitor. We always combine ARB. So along with sacubitril, we never combine AC inhibitor because sacubitril side effect is also angioedema. Sacubitril side effect is also angioedema. Now guys, apart from that, please remember these medicines can also cause increased level of potassium as a side effect. So medicine can cause hyperkalemia as a side effect. Now these medicines have two contraindication. Medicines have two contraindication, like these medicines should not be given to pregnant female. Now these medicines should not be given to a patient of renal artery stenosis. Medicine should not be given to a patient of bilateral renal artery stenosis. So the mnemonic is captopril. So in this mnemonic, we have the two contraindication, that is P and R, where the P stands for pregnancy, R stands for renal artery stenosis, bilateral renal artery stenosis. These medicines are contraindicated. Now guys, one more important side effect here is eye. Now these medicines can lead to increased level of creatinine. So they can increase the level of creatinine. So creatinine level is increased. So increased level of creatinine is a side effect of this medicine. So some important side effects we have covered, like C stands for cough, P stands for potassium, P stands for pregnancy, R stands for renal artery stenosis, I stands for increased creatinine, and S is already given to you. There is a drug over here which can cause sprue-like enteropathy. Now, sprue-like enteropathy is a side effect that is caused by olmesartan. So sprue-like enteropathy is a side effect that is caused by a medicine here, that is olmesartan. So olmesartan is a medicine that will cause sprue-like enteropathy as a side effect. Now let's talk about the fourth group of antihypertensive drugs. So we are discussing antihypertensives. First of all, we have talked about diuretics. Then we talked about ANS drugs. Then we talked about medicines which are RAS inhibitors. Now the medicines which are vasodilators. Now in vasodilators, the most important drug is calcium channel blockers. So calcium channel blockers, who will tell me which calcium channel blocker is used as antiarrhythmic? What is the name of a calcium channel blocker which is used as antiarrhythmic? Which calcium channel blocker is given for subarachnoid hemorrhage? So calcium channel blocker which is used as antiarrhythmic drug name is verapamil. So verapamil and to some extent diltiazem. So these are the two medicines which are given as antiarrhythmic drug, verapamil and diltiazem. Now, which calcium channel blocker is given for subarachnoid hemorrhage? For subarachnoid hemorrhage, the drug of choice is nimodipine. So nimodipine is a medicine which is a drug of choice for subarachnoid hemorrhage. Now, which calcium channel blocker is a drug of choice? Which calcium channel blocker is a drug of choice for hypertension crisis? So calcium channel blocker, which is a drug of choice for hypertension crisis, drug name is nicardipine. So nicardipine is a drug of choice for hypertension crisis. Nicardipine is a drug of choice for hypertension crisis. Now, who will tell me which calcium channel blocker is used as a tocolytic drug? Which calcium channel blocker is used as a tocolytic drug? And that is a drug of choice for preterm labor. So that medicine is the drug of choice for preterm labor used as a tocolytic drug. Drug name is nifedipine. So nifedipine is a medicine that is used as a tocolytic. It's a drug of choice for preterm labor. Now, who will tell me which calcium channel blocker is the longest acting calcium channel blocker and having the minimum side effect? So, longest acting calcium channel blocker having the minimum side effect. So, longest acting calcium channel blocker having the minimum side effect, the drug is amlodipine. So, amlodipine is a medicine. It's the longest acting calcium channel blocker having the minimum side effect. Now we have a drug which is the shortest acting calcium channel blocker. The shortest acting calcium channel blocker is clevidipine. So clevidipine is the shortest acting calcium channel blocker given by IV route. It's a second drug of choice for hypertension crisis. It's a second drug of choice for hypertension crisis. Drug name is clevidipine given by IV route. It's a shortest acting medicine. Now, which calcium channel blocker can cause constipation as a side effect? Which calcium channel blocker can cause constipation as a side effect? So, constipation is a side effect of which calcium channel blocker? I have forgotten. I have forgotten the name of a calcium channel blocker that can cause constipation. I will tell you the medicine that will cause gum hypertrophy. Okay, very good. So, you people remember. So constipation is the most common side effect. It's the most common side effect of verapamil. Now, gum hypertrophy is a side effect of most of the calcium channel blocker like nifedipine, diltiazem. All these medicines can cause gum hypertrophy as a side effect. So most of the calcium channel blocker can cause gum. Verapamil can also cause gum hypertrophy. So most of the medicines can cause gum hypertrophy. Now, protein hypersensitivity is a side effect of clevidipine. So clevidipine IV route, IV vial of the medicine contains protein. So clevidipine can cause hypersensitivity reaction. Now, who will tell me? Yes, Dr. Chaknachur, you have given the correct answer. Potato has given correct answer. Monkey has given the correct answer. Now, who will tell me which calcium channel blocker should not be given to moderate to severe heart failure? So moderate to severe heart failure. Moderate to severe heart failure, which calcium channel blocker is contraindicated? Answer is verapamil. So verapamil is a drug that is contraindicated in moderate to severe heart failure. So all these things we people have covered during our regular batch lecture also. Right? So verapamil is the answer. These are the MCQs that we have covered. Now the second group of medicines are nitric oxide donor. So here we have the drug nitropacide. And guys, we people have already covered. Nitropacide is drug of choice for intraoperative. This is a drug of choice for intraoperative hypertension crisis. It is a drug of choice for intraoperative hypertension crisis. We people have already covered the toxicity of medicine is cyanide toxicity, and the antidote also we have covered, that is hydroxycobalamin. So hydroxycobalamin is the antidote of nitropacide. Now, guys, please remember nitropacide is contraindicated during hypertension crisis that occurs during neurosurgery. So, nitropacide is contraindicated during neurosurgery because during neurosurgery, this medicine that can donate cyanide can reduce the level of SpO2 and therefore CNS gets stimulated. So, because of this cyanide, the medicine can stimulate the CNS. So during the neurosurgery, we never use nitropacide as a drug for intraoperative crisis. So for intraoperative hypertension crisis, this medicine is drug of choice. It can be given for any surgery. It can be given for any surgery, but not given for neurosurgery because this medicine can reduce the level of oxygen because of cyanide and can stimulate the CNS that you don't want during neurosurgery. Now, guys, we have some potassium channel opener which are not very important. Like hydralazine is given for PIH. Hydralazine is a medicine that is given for PIH. We call them potassium channel opener. And one of the important side effect of this medicine is this medicine can activate the renin-angiotensin pathway. So this medicine can activate the renin-angiotensin pathway. This is one of the important side effects. Now, minoxidil is nowadays given for alopecia. You must be knowing. It is given for alopecia. It is not given for hypertension. And where do we use diazoxide, guys? I have forgotten. I have forgotten where we use diazoxide as an antihypertensive drug. So why? Okay, diazoxide is given for which condition, guys? I've forgotten. It is not an antihypertensive anymore. Yes, it is given for. Yes, it is given for insulinoma. Yes, so diazoxide is a medicine which is not given for hypertension. Rather, this medicine is given for insulinoma. This is given for insulinoma, not given for hypertension. Now, guys, we have a drug, phenoldopam. Phenoldopam is a drug which is having the word dopam. This medicine is having the word dopam, and before the word dopam, we have the letter 01. So, this medicine will act on 01 receptor, dopamine 1 receptor, and it is given for the treatment of hypertension crisis. It is given for the treatment of hypertension crisis associated with oliguria. It is given for hypertension crisis associated with oliguria. The drug name is phenoldopam. So phenoldopam is given for hypertension crisis with oliguria. This is all about the medicines which are known as vasodilators. Now guys, after the vasodilators, we can discuss some other points like is missing here. So we can discuss some other points regarding the hypertension. So if I tell you, you have to choose the best antihypertensives. So when the patient is having the hypertension without comorbidity, when the patient will have the hypertension without comorbidity. So here, if the patient age is less than 55 years, you will mark AC inhibitor ARB as a drug of choice. When the patient age is more than 55 year, you will mark calcium channel blocker. If these medicines are not able to control the disease, if these medicines are not able to control the disease, the second best answer is you have to increase the dose of the medicine. You have to increase the dose of the medicine, but even then the BP is not controlled. Even then the BP is not controlled, then you will give these medicines in combination. You will give these medicines in combination. So hypertension without comorbidity, less than 55 year AC inhibitor ARB, more than 55 year calcium channel blocker. When the BP is not controlled, increase the dose. Still the BP is not controlled, give the medicines in combination. Even after that BP is not controlled, add diuretics. So add the diuretics, and thiazides are the diuretics which are given when there is no comorbidity. So when there is no comorbidity, we give thiazides. But even then BP is not controlled, we can add spironolactone in this patient treatment. So we can add spironolactone in this patient treatment. We can also add beta blocker. We can also add alpha 2 agonist. So any of the drug I can add. So we can add spironolactone, beta blocker, alpha 2 agonist. So this is how I will treat a patient of hypertension without comorbidity. Now guys, if we talk about hypertension with comorbidity. So if we talk about hypertension with comorbidity, right? So hypertension with comorbidity. So you have to choose medicine out of three groups. So every time you have to find out the answer from these three group of medicines only. So these are the first line drugs. These three are the first line drugs for hypertension. So whenever you have to mark the answer in MCQ, always find out the answer from these three. Anything which is fourth is always be ruled out. So anything which is fourth is always ruled out. Like let's take an example. If I say patient will have hypertension with CHF, so choose a one medicine out of these three, which can control CHF as well as hypertension both. So which medicine can control CHF and hypertension both? You will say, sir, furosemide is overall a drug of choice. This is the first medicine. If not able to control, I will add AC inhibitor ARB because they will also prevent remodeling. And if it is not able to control, I will add calcium channel blocker. So in this way, I have to choose. Similarly, if the patient is having hypertension with diabetes, guys, choose a medicine that will control both hypertension and diabetes. So which medicine can control hypertension and diabetes? So answer is AC inhibitor ARB. These are the drugs which can control diabetes plus hypertension. After that, you will choose calcium channel blocker, and the last you will choose diuretics. Last, you will choose thiazide diuretics because one of the important side effect of diuretic therapy is diabetes mellitus. So diuretics can cause diabetes mellitus as a side effect. So in this way, you can choose patients who have hypertension associated with risk of hypotension. So patients who have hypertension associated with risk of orthostatic hypotension. So here the best medicines are AC inhibitor ARB. Now guys, very important is hypertension associated with CKD. So whenever guys you get this question on hypertension associated with CKD, the first thing you have to choose is first thing you have to find out whether the patient is having the proteinuria, patient is not having the proteinuria. So if the patient is having the proteinuria, you have to choose a medicine that will treat proteinuria plus hypertension both. You have to choose a medicine that will treat proteinuria plus hypertension both. So AC inhibitor ARB can be given as a best medicine. Even then it is not controlled. You can give calcium channel blocker, and the last preferred is furosemide. Right. So guys, here you have to understand, here the patient is having hypertension with comorbidity. So because of hypertension with comorbidity, you will not choose thiazides because thiazides are not active in CKD. So no action of thiazide will take place. No action of thiazides will take place in patients of CKD. That's why you will choose furosemide over here. You will choose furosemide over here. And guys, in case there is no proteinuria, then the second question you will ask from the MCQ is whether the edema is there or not there. So when the proteinuria is ruled out, then you will say protein edema is there or not there. So when the edema is there, then you have to choose a medicine that will control edema. That will control edema plus hypertension both. So when you want to control edema and hypertension both, you will choose furosemide. Second best medicine is AC inhibitor ARB because they will not do anything to the edema. The last option is calcium channel blocker. The reason is calcium channel blocker side effect is edema. Calcium channel side effect is edema. So AC inhibitor ARB will be the second best medicine to be chosen here. Right. Now, when the patient is not having the proteinuria, you can see no proteinuria, no edema, nothing is there. Now, there is no fixed guidelines. You can give any of the drug. You can give any of the drug, AC inhibitor or calcium channel blocker. Any of the medicine can be chosen as a first medicine. So, any of the medicine can be chosen as a first medicine if there is no proteinuria, no edema in patients of CKD. Right? Guys, there is one big exception that you must be knowing. What is the exception here? The exception here is, you must be knowing, what is the exception? The exception here is when the patient is having the hypertension associated with coronary artery disease. When the patient is having hypertension associated with myocardial infarction or angina. So hypertension with myocardial infarction or angina. So here there is two options. Either you can choose AC inhibitor ARB or you can choose beta blockers. So although beta blockers are not the frontline medicines, they are not the first line drugs, but still in patients of coronary artery disease, you can choose beta blocker as a first group of medicines in this patient. This is all about hypertension. Let's move on to the angina. So guys, what are the first line drugs for angina? First line drugs are nitrates, right? So please remember, nitrates are the drugs which are drug of choice for acute angina. Nitrates are drug of choice for acute angina, and the main mechanism of action of nitrate in angina is venodilation. So nitrates' main mechanism of action is venodilation. They are the drug of choice for acute angina. Now, beta blockers are the drugs which are considered as drug of choice for maintenance treatment of classical symptoms. They are the drug of choice for maintenance treatment of classical symptoms. And calcium channel blockers, which are the coronary vasodilators, they are the drug of choice for maintenance treatment of vasospastic symptoms. Right? So overall, for acute attack, drug of choice nitrates, but beta blockers are best medicine for maintenance treatment of classical symptoms, and we give calcium channel blocker along with beta blockers because they will take care of the vasospastic symptoms. So both symptoms can be taken care of. So these two medicines are given in combination. These two medicines are given in combination for maintenance treatment. So these two medicines are given in combination for maintenance treatment. One will take care of the classical symptom, other will take care of the vasospastic symptoms. Now we have some problems with nitrates, like nitrates are volatile drugs, so should not be left open. So they should not be left open, otherwise they will evaporate. Now the long acting preparations. LAP means long acting preparations. So long acting preparations of the nitrates, and if you give nitrates with high frequency, there is a risk of tolerance. So there is a risk of tolerance that is seen with the nitrates. Third problem in nitrate is hypotension. Nitrates can cause hypotension. As a result of that, they are contraindicated when the systolic blood pressure is already less than 100, and they are also contraindicated with phosphodiesterase 5 inhibitors. So hypotension is a side effect. So this should not be given in low BP patients and should not be given with phosphodiesterase 5 inhibitors. Now all nitrates have high first pass metabolism. All nitrates have high first pass metabolism except isosorbide, mononitrate. So isosorbide mononitrate, that is IMN. So IMN has no first pass metabolism. All medicines have high first pass metabolism. Now headache is the most common side effect of nitrates. Headache is the most common side effect of nitrates. So we have discussed the important problems of nitrates. Now if we talk about other drugs of angina, we have the medicines like ivabradine, fasudil, nicorandil, and ranolazine. Dr. Mohammed, we can combine beta blocker with calcium channel blocker except verapamil. Verapamil should not be combined with beta blocker. Verapamil should not be combined with beta blocker. Dipins, I am specially mentioning here dipins. Dipins can be combined. Dipins का तो side effect है reflex tachycardia. Dipin side effect is reflex tachycardia that is taken care by beta blocker. So they are combined together. Guys, your break time is 8:30. Break time is 8:30 because we are lagging behind. We are yet to cover many topics. So in 8:30 we will take the break, and then in break I'll plan that how to go about this thing. Dr. Zori, the LAP means long acting preparations. Long acting preparations. Long acting preparations of nitrates like patch, skin patch. Long acting preparations are like skin patch. And if you give medicine with high frequency, risk of tolerance is there. Now, guys, what is the mechanism of action of these four drugs? So, ivabradine is a drug that will cause bradycardia. So, ivabradine is a medicine that will cause bradycardia by inhibiting the funny channel. So, this medicine mechanism of action by inhibiting the funny channel, this will cause bradycardia. Now, fasudil is a drug which is a Rho kinase inhibitor. This is a Rho kinase inhibitor given for angina. Fasudil is a medicine that is a Rho kinase inhibitor given for angina. Now, nicorandil is a medicine which is having the word CO. CO means channel opener. So, this medicine is a channel opener. Now, which channel is opened by the drug? So, nicorandil is a channel opener. It's a potassium channel opener. So, nicorandil is a potassium channel opener. And ranolazine is a drug which is having the word lazy. This is having the word lazy. So please remember, anyone who is lazy is always late in life. So anyone who is lazy is always late. So it's a late sodium current inhibitor. This is a late sodium current inhibitor. And also this medicine is PFOX inhibitor. It's a partial fatty acid oxidation inhibitor. So this is a late sodium current inhibitor. Also, this medicine is partial fatty acid oxidation inhibitor. It's a partial fatty acid oxidation inhibitor. This is all about angina. Now, guys, after this angina, we can have the congestive heart failure. Now, in congestive heart failure, we have acute CHF. So, in acute CHF, all medicines are given by IV route. All medicines are given by IV route. So the medicines which are given can be given to reduce preload. So best medicines, best drugs are medicines which can reduce the preload. So they are the venodilators. Now what is the drug of choice? Which medicine is a drug of choice for acute heart failure? Answer is furosemide. So furosemide is a drug when given to a patient. This medicine first of all act like a venodilator. So by increasing the level of prostaglandin E2, this will act as a venodilator. So this is the overall drug of choice. Then its diuretic effect will start. Furosemide first of all act as a venodilator, then the diuretic. Other two medicines which are venodilator are morphine and nitroglycerin. So morphine and nitroglycerin are other two medicines which are venodilator. We have one more medicine which is venodilator. Drug name is neseritide. So neseritide is one more medicine. Neseritide is one more medicine which is a BNP analog. This is a BNP analog. So this medicine can be given as a one more drug, that is venodilator. So four medicines can be given as a venodilator. Best is furosemide. Other medicines are like morphine, nitroglycerin, and neseritide. Now guys, if the patient's symptoms are not controlled or if the patient ejection fraction is very low, the second group of medicines, which are known as inotropics, they are only been given when this criteria is satisfied. So when this criteria of ejection fraction less than 35 to 40, or we can say the patient is in cardiogenic shock. The patient is in cardiogenic shock, then there is a need to give inotropics. So which inotropics are given, that we have already covered. So in patients of heart failure, when the systolic blood pressure is more than 80 by 90, then we will choose dobutamine. So we have already covered when the BP is maintained, dobutamine. When the BP is low, noradrenaline. When there is a oliguria, dopamine. So heart failure with oliguria, we will choose dopamine. If there is arrhythmia, we will choose digoxin. If there is arrhythmia, we will choose digoxin. So if there is arrhythmia, we will choose digoxin, right? So digoxin is chosen, right? So if systolic blood pressure more than 80 by 90, dobutamine. Systolic blood pressure less than 80 by 90, 80, 90, noradrenaline. Oliguria, we will give dopamine. Arrhythmia, we will give digoxin. And guys, if there is a pulmonary artery hypertension, like acute CHF associated with pulmonary artery hypertension or right heart failure. Pulmonary artery hypertension and right heart failure, then we will choose a group of medicines. We call them inodilators. So we have the medicines, we call them inodilators. So inodilators are the medicines which are used, like the medicines are embrenon and the milrinone. So medicines are like embrenon and the milrinone. These medicines can be chosen. Now we can also use some medicines which are arterial dilator. So medicines which can decrease the afterload, arterial dilator. So medicines are like nitroprusside, hydralazine are also approved for acute heart failure. So these are the drugs which are given for acute heart failure. Now, once the patient gets stabilized, we will start the medicines for maintenance treatment. We'll start the medicines for maintenance treatment. So we can categorize the patient in grossly two groups: heart failure with reduced ejection fraction. So we can say the patient will have the heart failure with reduced ejection fraction, and we will have the patient of heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. So heart failure with reduced ejection fraction, here the ejection fraction is near about 40%, but in preserved ejection fraction, there is more than 50%. Now intermediate is 40 to 50. In between that, in between two, we have the intermediate. Now guys, for the reduced ejection fraction, we have to give the first line drugs. Now the first line medicines are those which are given to reduce the remodeling so that the survival is improved and mortality is decreased. So which medicine can improve the survival and reduce the mortality? The best medicine we have discussed is Arni. So Arni is the best medicine that is chosen, and we have already covered this is a combination of valsartan plus sacubitril. So valsartan plus sacubitril, this is the medicine that is chosen, but because the medicine can cause angioedema, patients should not have the history of angioedema. Plus, the patient blood pressure should be high because one of the side effect of medicine is low blood pressure. So one of the side effect of medicine is low blood pressure. Plus, medicine is costly. Patient is able to afford the medicine. Now, this medicine should not be given to a patient who are pregnant, patients who have hyperkalemia, patients who have liver disease, or patients who have angioedema. Right, guys? So out of the above three criteria, if these three are satisfied, then we start earning. Now, if any of the criteria is not satisfied, then we have the alternatives. So what are the alternatives? If there is no affordability, patient cannot afford, then we can switch to ACE inhibitor. Like we can start with ARNI and gradually we can switch to ACE inhibitor. Now guys, whenever you switch ARNI to ACE inhibitor, whenever we switch ARNI to ACE inhibitor, you have to maintain a minimum time gap of 36 hours. So whenever we switch from ARNI to ACE inhibitor, we have to maintain a minimum time gap of 36 hours. Otherwise, the patient will have the risk of angioedema. Patient will have the risk of angioedema. Now, if the patient is having the cough or the angioedema history already, if the patient is already having the history of cough and angioedema, then you will not choose ARNI, you will not choose ACE inhibitor, then you shift to medicines which are angiotensin receptor blocker. They end with the word sartan. But guys, all the above medicines can cause hyperkalemia. Like ACE inhibitor can cause hyperkalemia, ARNI can cause hyperkalemia, ARBs can cause hyperkalemia. So if the patient is having the hyperkalemia, then above medicine cannot be given. So above medicine cannot be given to that patient. So now we will give a combination of the drug that will not cause hyperkalemia. So this will not cause hyperkalemia as a side effect. So this combination is given. This combination is combination of hydralazine plus isosorbide dinitrate. So hydralazine plus isosorbide dinitrate combination is used in this patient who has the history of hyperkalemia or the patient who suffers from hyperkalemia. Now guys, apart from these medicines which are given to reduce the remodeling, we have the drug that is given to reduce the congestion. So which medicine is given to reduce the congestion? That is furosemide. So furosemide is drug of choice to reduce the congestion, and we have the medicines which are given to prevent tachycardia, that is beta blocker. So you can read from here the three medicines that we can give as a first line drug. So in the patient prescription, three medicines should always be a part. Medicines blocker of renin pathway, diuretics, and beta blockers. Now we have some second line drugs which are the alternatives. So which other medicines can reduce the remodeling? We have aldosterone receptor antagonist. So aldosterone receptor antagonist, like we have a drug eplerenone. So eplerenone is a medicine which is a aldosterone receptor antagonist. This medicine can be used. Beta blockers can also reduce the cardiac remodeling, but they are not the first line drugs. They are given when the first line medicines are not able to control or can be given as an alternative. Now, the medicines that can be given to reduce congestion are SGLT2 inhibitor. Furosemide is first. If not able to control, we can give thiazides, we can give SGLT2 inhibitors. So if you want to reduce congestion, we can use thiazides. So thiazides are always given as add-on drug to furosemide. They are never given as a only monotherapy. They're only given as an add-on drug to furosemide. Next is SGLT2 inhibitors. They can also reduce the congestion. The medicine which can reduce tachycardia, instead of beta blocker, you can also give ivabradine. You can also give ivabradine. And there is an inotropic that can be used. The inotropic which can be used as a second line drug is digoxin. So digoxin is inotropic that we can use over here. So these are the medicines that are given for heart failure with reduced ejection fraction. Now, heart failure with preserved ejection fraction, we have to only reduce the congestion. The first line medicines are, the first line drugs are those that can prevent the congestion. Basically, these are the diuretics. So diuretics are the medicines which are only be useful. So furosemide, SGLT2 inhibitor, aldosterone receptor antagonist like eplerenone can be used. These are the first line drugs. The second line medicines are not important here. So RAS inhibitors and beta blockers can be given. मोहम्मद thiazides are given after furosemide. So यहाँ पे ना water retention नहीं होगा because furosemide will not let the water to retain, right? So thiazides, when its studies have shown when we add thiazides to the furosemide, then thiazides will cause loss of sodium. So that sodium, if it is lost, then it is useful. Like the additional loss of sodium caused by thiazides, that is useful. Okay, guys, last medicine in CHF, that is digoxin. So we talk about this medicine digoxin in detail. So digoxin is a drug that starts from alphabets di. So di means two mechanism of action, two indication and two contraindication. So medicine name starts with the word di. So di means two mechanism, two indication, two contraindication. So what are the two mechanism? This medicine is inhibitor of sodium potassium ATPase pump, plus this medicine can stimulate the vagus nerve. So medicine can stimulate the vagus nerve as well as inhibit sodium potassium ATPase pump. Indications are it is given for congestive heart failure as well as it is given as an anti-arrhythmic drug. It is given for the treatment of supraventricular arrhythmia. Two contraindications are HOCM and WPW syndrome. So two contraindications are HOCM and WPW syndrome. So two mechanisms, two indications, two contraindications. Mechanisms are sodium potassium ATPase blocker and stimulation of the vagus nerve. Two indications are CHF and antiarrhythmic drug. Two contraindications are HOCM and WPW syndrome. Now, G stands for its most common side effect. So most common side effect is GIT toxicity like nausea, vomiting and diarrhea. And G also stands for its rare side effect, that is gynecomastia. So rare side effect, gynecomastia, most common side effect, GIT toxicity. Now O stands for optic side effect. Optic side effect is yellow vision. So this medicine can cause yellow vision as a side effect. Now this medicine is X means inhibitor. This medicine is inhibitor of cardiac nodes. So can result in bradycardia, can result in heart block as a side effect. Can result in bradycardia, can result in heart block as a side effect. For this heart block, we have to give atropine. For this heart block, we have to give atropine as a drug of choice. Now, this medicine can increase the level of calcium in, this can increase the calcium in cardiac muscles. As a result of that, this medicine can result in ventricular arrhythmia. This medicine can result in ventricular arrhythmia as a side effect. So medicine can increase calcium in muscles, can result in ventricular arrhythmia as a side effect. Now to control this ventricular arrhythmia, we will give lidocaine. So lidocaine is given as a drug of choice for ventricular arrhythmia. It is given as a drug of choice for ventricular arrhythmia caused by digoxin. Now, this medicine can cause a unique toxicity. The unique toxicity of medicine is non-PSVT with heart block. So, non-PSVT with heart block is a unique side effect of digoxin, right? Non-PSVT with heart block is a unique side effect of medicine. Now here the atria will contract at very high beat, more than 200 to 3 beats per minute. AV node is blocked. AV node is blocked. Atria is contracting at very high rate, and the ventricle will contract at very low rate. So this is the unique thing caused only by digoxin. There is no other drug which can cause this kind of problem where the atrial contractions are more, ventricle is less, and the AV node is blocked. And for the treatment of this non-PSVT with heart block, we have to give the antidote, and the antidote of choice is Digibind. So the antidote of choice is Digibind that we will give. So Digibind is the antidote that we will give in this patient for the treatment of non-PSVT with heart block. Now, what are the risk factors for digoxin toxicity? So, risk factors for digoxin toxicity, guys, please remember the first is electrolyte imbalance. So, electrolyte imbalance like hypercalcemia, hypomagnesemia, hypokalemia. Next is if the drug elimination. If the elimination of drug is reduced from the body. So, in which condition drug elimination is reduced? If the patient has got CKD, if the patient is old, so patient is CKD, patient is old patient, and in kidney, guys, please remember this medicine is eliminated by P-glycoprotein pump. It is eliminated by a pump. We call it P-glycoprotein pump. Now, this P-glycoprotein pump is also known as ATP binding cassette pump. This is also known as ATP binding cassette protein. So P-glycoprotein is also known as ATP binding cassette protein, and we say that this is the product of a gene. We call it MDR1 gene. So this is a product of a gene. We call it MDR1 gene. So we have a P-glycoprotein which has a three different names: P-glycoprotein, ATP binding cassette, and MDR1 gene. So guys, we have some drugs. We have some drugs which can inhibit this P-glycoprotein or MDR1 gene or ATP binding cassette protein. The mnemonic to remember the medicine is CAVE-Q. So mnemonic to remember the medicine name is CAVE-Q, where the C stands for cyclosporin. C stands for cyclosporin. C also stands for clarithromycin. C also stands for clarithromycin. Now A stands for amiodarone. A stands for amiodarone. V stands for verapamil. So V stands for verapamil. E stands for erythromycin. E stands for erythromycin, and Q stands for quinidine. So these are the six medicines which are the P-glycoprotein pump inhibitor, and patients will have side effects of digoxin when we use digoxin along with the six medicine: cyclosporin, clarithromycin, amiodarone, verapamil, erythromycin, and quinidine. Apart from that, hyperthyroidism, hypothyroidism can lead to this problem, and apart from that, any disease of cardiac muscle. Any disease of cardiac muscle Any disease of cardiac muscles like myocarditis, myocardial infarction can increase the risk of digoxin toxicity. This can increase the risk of digoxin toxicity. So these are the risk factors for digoxin toxicity: electrolyte imbalance, when the drug elimination is reduced, plus hypothyroidism both, and any disease of cardiac muscles can lead to increased risk of digoxin toxicity. Last topic before we take the break: anti-arrhythmic drugs. So guys, I have already given you the notes of this anti-arrhythmic fully, right? So you can read by yourself. So please remember, we'll discuss only the side effects of these medicines because of lack of time. So three important anti-arrhythmics are lignocaine, amiodarone, and adenosine. Right, guys? So please remember, lignocaine is a drug. Lignocaine is a medicine. The important side effect is CNS toxicity. Important side effect is CNS toxicity. So first sign which patient can have the tremors. After that, the patient can develop seizures. And after seizures, ultimately all CNS centers get suppressed. So respiratory center, vasomotor center ultimately get suppressed and patient will die. Right? So guys, please remember, whenever lignocaine toxicity will occur, initially there is a CNS excitation. Initially there is a CNS excitation followed by the CNS depression. So initially there is an excitation followed by the depression. So first of all, there is excitation, then we have the depression. So patient will have the tremors and seizures, CNS excitation. Then patient will have the CNS depression, and finally the patient will die. right? Now, amiodarone side effects. So if we talk about side effects of amiodarone, if we talk about the side effects of amiodarone, now this will cause side effects like pulmonary fibrosis. This will cause side effects like pulmonary fibrosis. This will cause side effect like liver fibrosis. This will cause side effect like hyperthyroidism, hypothyroidism. So there is a mnemonic to remember the side effect. Mnemonic is please check. Mnemonic is please check PFT, LFT, and TFT of the patient when you give amiodarone. So PFT stands for pulmonary fibrosis, LFT stands for liver fibrosis, and TFT stands for hyper and hypothyroidism both. Apart from that, guys, in this mnemonic, please check P stands for blue pigmentation of skin. So P is for pigmentation of skin, and C stands for corneal deposits. Now, the side effect of adenosine. Now, adenosine is a drug which is a drug of choice for PSVT. This is a drug of choice for PSVT. We have discussed already before. Now, important side effect is bronchospasm. So, this should not be given in patients of bronchial asthma and COPD. This should not be given in patients of bronchial asthma and COPD. So, in these patients, bronchial asthma and COPD patients, drug of choice for PSVT, you will mark verapamil. So verapamil is a medicine you will mark as a drug of choice for the PSVT. Right, guys? So this is all about the four topics that we have covered. So we have covered ANS, we have covered respiratory, we have covered kidney, and we have also covered CVS. So four topics have been finished.